Recording?
Not yet. Should I start?
Yeah, please start because we'll
Yes,
be live.
Thomas.
Yeah, I have started.
Okay.
Started?
Just a moment, sir.
Okay.
Ashok, shall I toggle? Ashok, shall I toggle on the both?
We are live, Samshu.
Yeah, we are live.
Yeah, you can toggle on. I've already toggled on. You can just start on the YouTube.
We are live, sir.
Okay, I'm sharing the screen.
Yeah, please go ahead, sir.
Please, everyone, please mute yourself. Please mute everyone, mute yourself.
Yeah, I'm making a note.
Ravi, my slide can be seen.
Yeah, visible, sir. Please go
Okay.
ahead.
Good evening, everyone. A warm welcome to all our colleagues who have logged in for this module, Pediatric Orthopaedics, the first part. I welcome you all and thank you for joining to our module for the day. I'll be the moderator for today for this webinar. I'm the chairman, I'm Dr. Rajagopalan. I'm the chairman of the IOA PGE Teaching Committee, and I'm from Pondicherry. And today our module is on pediatric orthopedics, and we have 4 faculty for you today. And the next Saturday will be the second module. And before I proceed, I'd like to introduce you our IOA team who are the brain behind this program. We started with 2 hip sessions, 2 spine sessions, 2 shoulder sessions, elbow, hand, and then we had the pediatric orthopedic. And our president, Dr. R.C. Meena, is the one who really encouraged us to start this. And Dr. Shivashankar, our president-elect, Dr. Ramesh was the vice president, and Dr. Lalit Maini, our editor of Indian Journal of Orthopedics, Dr. Sandeep Kumar, who is our joint secretary, and Dr. Sanjay Dhawan, who is our joint secretary. And along with me in the team of our IOA PGE teaching program are Dr. Harsha Shah from Bangalore, Dr. M.M. Ray, and Dr. Kagata and Dr. Rajesh Goyal. And we have an excellent faculty today and also for the next week. One of the probably, I think I would say we have really proud to have a very great team for this program. And along with our team, the Ortho TV and the webinar coordinator Ravi Chauhan are the people who are really responsible for the all the activity that has gone on till today. Our faculty for today, I'll just start with Dr. Jayant Sambat, the consultant pediatric orthopedic surgeon from Bangalore. He is editor of International Journal of the Pediatric Orthopedics, which is the official journal of our POSI. And he is also a director of the Pragati, which is a comprehensive cerebral palsy care. And also he is the Bangalore Institute of Movement Research and Analysis. Welcome to you, Dr. Jayant, and thank you for keeping a Saturday evening free for us. Thank you, Jayant. Dr. Hitesh Shah is the professor and he's in charge of the pediatric orthopedic unit in KMC Manipal. He's the treasurer of the POSI. He has been a traveling fellow for and also have been published more than 80 articles in many international journals. Dr. Hitesh, thank you so much for sparing the time for us. Dr. Maulin Shah, he is a consultant pediatric orthopedic surgeon, and his biodata is too long for me to read everything here. So he had a vast experience and exposure to so many different places. He is the president of Ahmedabad Orthopedic Society, the editor of Pediatric Orthopedic Science, PORS, which is the official journal of Pediatric Orthopedic Society of India. And he also editor of Challenges in Management of Pediatric Joint and Joint Infections, a concise book on osteoarticular infections. And he has got experience from USA, Canada, and many other places. Dr. Maulin, thank you so much. And I know today you are busy. In spite of that, you have tried our time for you. Thank you so much. Rojita is well known to, I think, everybody, not only in the pediatric side, but all of us. And she's a consultant pediatric orthopedic surgery and pediatric hand surgery. She works in specialty center and Anavadi hospital. She has anyway a vast list of awards. I am not going to read all of them. It's going to take a long time, and I'll preserve it for. I can see one awarded prestigious Masalawala award. He was an examiner at Masalawala for my deortho. Thank you, Dr. Rajita, for being with us and sparing your time for us. Thank you all. And with a brief introduction, I will go on to the program today. A small change in the program. Dr. Maulisha will be starting the program, and he will be presenting a case of a congenital shortness of tibia to you. Over to you, Dr. Maulisha.
Yeah.
I'll just leave the thing 1 second.
Yeah. Shall I share my screen now?
Yeah, please.
Okay, so thank you very much, Dr. Manish and Dr. Rajgopalan sir, for giving me an opportunity. And I was told by Dr. Manish that I have to present this as a short case and how residents would present and how the examiners would question them. So I'll present the case, I'll put forward the question, and I'll answer those too. So, and I hope at the end of this, they'll learn how to manage this anterolateral bowing of tibia. So looking carefully at this video, first of all, so this mother came to us and with a complaint that my child is not standing properly, and she, for last 1 week, child is not bearing weight on the right leg. And if we see this carefully, there is some swelling along the lower diaphysis of the leg, tibia, and there is bowing of tibia, which is a little bit more compared to the left side. So this is not a case of bilateral bowing, which is usually seen physiologically at this age group, but this child had unilateral bowing. And by just looking at this video, the examiner might ask that, what are the key findings you observed? And as a resident, I would be very precise in saying that the child has asymmetric curvature of tibia, and one can easily see anterolateral bowing of right tibia. On the left tibia, there is just the bowing, and which is a physiologic. So there is asymmetry, which is very conspicuous. And child avoids weight bearing. So when mother makes the child bear weight, child does not put the whole foot down. And so that is probably painful for the child. And we should also check the limb length of this child, whether that limb is short or not. But apparently the child avoided the weight bearing. So after this brief inspection, the next question as an examiner, one would like to ask the student, at what point in history you would like to inquire when you see such unilateral swelling and inability to bear weight for 1 week? So yes, the trauma is the most common thing which one should ask, that whether child had a fall or child was fall accidentally when it comes to this small age. But in this case, there was no history of local trauma or fall. So trauma is out of question. And certainly we should ask whether there is any signs of infection, because an infection would lead to an abscess formation, and that would lead to a localized swelling. But in this case, parents were very clear that there is no history of fever or infection elsewhere in the body, that is upper respiratory tract infection or URTI or GU or GI infection. And there was no fever whatsoever. Child has been happy, but as soon as we make them stand, he has this episode of crying and not bearing weight on that side. So infection is also out of question, but these two important questions to be asked. The third thing we should ask is the onset of this finding, because that will be also important clue about diagnosis. And parents told that they have observed a little bit of bowing on one side more than the other since the early infancy. Just after a month of the birth, we had seen this curvature. And the last thing we have to ask whether it has progressed or it has been a static one. And mom say that I feel that this curvature has increased over last 4 months. And they are more concerned that with this curvature, now my child is not bearing weight. So those are the important points in history. Now, once the resident get this video or just a visual examination and the history, one would like to do local examination more closely. And let's see what are the local examination findings here. So child retracts the leg on touching the right mid tibia. So it certainly is tender and there is swelling, but there is no local warmth or redness or like a local increase in temperature, which would be suggestive of infection. So that signs are not there. And of course, as we discussed, there is anterolateral bowing more on right than the left. And these are the clinical pictures. You can see that right side is more curvature. So as an examiner, the next question would come to you is, would your examination be limited to the extremity? Or you would like to examine further? Or you would just like to investigate this child now? And whenever we see an isolated swelling on one of the extremities without signs of trauma or infection, we must check the whole trunk and the whole back and upper leg also. And you will be surprised to see this kind of marks on the body. So these are the coffee marks and these are termed as cafeolate spots. So cafeolate spots, more than 6 in number, more than 5 millimeter in size, they are considered a significant finding. Most of the time parent would say these marks are there since birth and it has not changed much, but these are not the routine skin marks. These are cafeolate spots, and that cafeolate spots is commonly seen in few etiologies, like the common ones are neurofibromatosis 1, fibrous dysplasia associated with McCune-Albright syndrome, sometimes Fanconi's anemia or tubular sclerosis. These are the rare pathologies, but 2 pathologies which when pediatric orthopedicians look at them, we think about either neurofibromatosis or fibrous dysplasia. Now, sometimes if a learned examiner comes, they would ask the literal meaning of cafeolate spots, that what do you mean by cafeolate? So this is coffee with milk. It's a French word, and it means that milk, when just mixed with coffee, it will give that stain. And typically in literature, the examiner may also ask, looking just at cafeolate spots, can you differentiate between neurofibromatosis and fibrous dysplasia? The neurofibromatosis, we see a bit of regular periphery of these spots, while in fibrous dysplasia, these are the raised periphery. And it's also said as it's a beach of California and beach of Maine. So the ones which are associated with the fibrous dysplasia, they are very ragged margins and they are very irregular. So yes, this cafeolate spots are a significant finding. You see multiple, and if you fail to examine the trunk, then the examiner may, it will be a negative point in your short case also. So let's see the X-ray now. And so this is the typical X-ray. And if we have to explain the X-ray, then this is a tibia X-ray. You can see a hairline fracture going through the diaphysis, a little bit of spiral fracture, but there is also presence of some lytic changes in the tibia. And there is something wrong with the lower middle diaphysis of fibula as well. So it's not only tibial lesion, there is something wrong here also. So there are lytic areas with an hairline fracture, which might have made the child painful. So with this X-ray, with this examination and with this history, with the presence of multiple cafeolate spots, whenever you are asked the diagnosis, I don't think you have to go for any further MRI investigations, but this is a typical diagnosis of right side anterolateral bowing of tibia due to neurofibromatosis 1. Now, there are, NIH has laid down diagnostic criteria for neurofibromatosis 1. And if 2 or more criteria are present, then the diagnosis is confirmed. And those criteria are more than 6 cafeolate spots, a bony lesion, Lisch nodule, a first degree relative having neurofibromatosis, and then sometimes optic glioma and freckling along axilla and neck. These are the findings which takes you towards the diagnosis of neurofibromatosis. So in clinical practice, when you see two of them, a bony lesion with multiple Caffeine spots, your diagnosis is pretty sure this is neurofibromatosis 1. If you want to confirm it further, you can do some genetic studies. Now coming to this, the question can come now, what can be the natural history of this anterolateral bowing of tibia? How early we need to treat them? What happens if we leave them alone? And the answer to this is about 90% of this anterolateral bowing of tibia with neurofibromatosis, they ends up into frank pseudoarthrosis by the age of 2 years. Mostly once the children start walking, they with a trivial trauma, they sustain fracture, and those simple hairline fractures or deformity may end up in a frank pseudoarthrosis. There are 10% children, if they are protected, if they are splinted, then they may not fracture as even though up to adolescent, but that percentage is pretty small. So this is what happened with this child at 1 year of age. You can see that this child ended up into a frank pseudoarthrosis of tibia, and there is also tibial bowing, and the opposite extremity is normal. So the question would be, what would you do now if this child is presented to 1 year? And we tend to just wait, and we give them a splint to prevent further angulation, to prevent further fracture of fibula. And many a times this is because the bone fragments are so small to give a robust fixation at this age. And so we tend to splint them till up to 2 or 2.5 years before we consider surgical intervention. Although we introduce this surgical intervention and the chances of union to this family right from the outset. So we have followed this child, and you can see at 2 years, even the fibula has fractured now, because child and family was not very cooperative, compliant with the splinting. And at 2.5 years, your child has presented with this radiologic picture. And if we explain this radiologic picture, there are 4 types of neurofibromatosis induced pseudoarthrosis tibia. This classification is based by Dr. Alvin Crawford. And type 1 is just bowing. Type 2 is a sclerosis and obliteration of medullary canal. Well, type 3 is a cystic changes within the tibia, and type 4 is a complete fracture. So now this patient has ended up into type 4 Crawford congenital pseudoarthrosis of tibia. So this classification can be asked to you. So now we have problem of deformity, we have short limb, we have pseudoarthrosis both in tibia and fibula. Now someone would ask you that why the fractures associated with NF1 fails to unite. Why they don't unite just like normal fractures? And we always, I have seen some patients where fibula was fractured and someone would do tibial osteotomy, thinking that the length of fibula is, length of tibia is not allowing the fibula to unite, and then both the fractures will fail to unite. So it's a real problem. The answer to this very important question is, in neurofibromatosis 1 associated pseudoarthrosis, normal marrow is replaced by the fibrous hematoma. And this hematomatous periosteum lacks osteoclastic bone formation. So this periosteum does not throw new bone, it lacks the osteoclastic activity. And so it prevents normal bone healing potential. And that's why this hematomatous periosteal resection during surgery is a very important step in achieving union. So this is a very important question, and we must differentiate those simple fractures in children which fail to unite with plaster in certain period of time. A child less than 4 years would heal in about 3 weeks' time with a simple plaster. If child fails to unite, one should look for the signs of neurofibromatosis in this children. Now, the question which is very important, and it was debatable in pediatric orthopedics community, that what is the ideal age of intervention? How long we should observe? How long we should splint them? There is a nice paper from Dr. Benjamin Joseph from Manipal, And this was published in 2003, because at that time, European Society said that intervention should not be done before 3 years. But in Dr. Benjamin Joseph's series, he found that intervention can be done conveniently between 2nd and 3rd year of life. It has shown less chances or less degrees of limb length discrepancy, and there was similar union rates. So we all follow this principle. We tend to wait for 2 to 2.5 years, and we tend to operate between 2nd and 3rd years of life. The question can be asked, what are the principles of management of congenital pseudoarthrosis tibia? And I always tell there are 4 basic principles. The one is you have to resect the pseudoarthrosis. Pseudoarthrosis is not just the bone, but also the hematomatous periosteum, not on the sides, but on the 360 degrees you have to excise, because if you leave behind that periosteum, it will hamper the bony union. So you have to resect the diseased part and dock the healthy bones together. Secondly, you have to correct the deformity. And to correct the deformity, you have to put some intramedullary rod, because deformity correction is very essential. If the deformity is not corrected, then you may end up into refractures. And refracture is a very important, it's a complication of CPT treatment. Bone grafting is essential because sometimes the bone ends, which might not be healthy, but you want to bypass that unhealthy bone segment, and you want to have a bridging union, or nowadays they are suggesting to have cross union so that this deformity will not fracture again. So bone grafting is very critical part. And finally, the prevention of refracture in future, that I'll tell you how we approach that also. So these 4 basic principles you have to tell in your exam, and these are really satisfactory answer to your question of how to treat CPTs. Now, the question is, there are different modalities available to treat congenital pseudoarthrosis. 3 modalities have been time tested and have been published extensively, and that is expected from examiners, from students or residents to answer these 3 methodologies at least. And these 3 methodologies are intramedullary rodding and cortical bone grafting. Cortical bone grafting because the cortical bone graft takes longer time to resolve, and the pseudoarthrosis tibia takes longer time to heal. So we want such graft that would last there for longer time. And as you all know that the cancellous graft has less time for it get resolved earlier than cortical graft. So we prefer cortical graft. The second is vascularized fibula transfer, because the bone ends are avascular and non-healthy. We want to bring a vascularized fibula, and this vascularized fibula transfer has rate of healing in about 80% patients. Dr. Joseph's series and intramedullary rodding and cortical grafting had primary union rate of 80%, and after secondary bone grafting, it was 92%. So in their series, about 8% children failed to unite. And Elizaro technique, which was popularized by Dr. Elizaro and later by Dror Pele, they have success rate of almost 90 to 95%. So these 3 methodologies are the key methods which you have to explain, which you have to answer in your exam. And we'll go in little detail how we have to deal with this. Now, this is intramedullary and intramedullary rodding and cortical grafting. The first step is to resect the pseudoarthrosis, and then you take a graft from the contralateral sheen of tibia, and then you cut them into 3 parts. And after putting a transcalcaneal talar tibial rod like this, a rush rod, it gives you more stability. And once you fix this with the rod, you put an onlay graft like this. So that is the technique of intramedullary rodding and cortical bone grafting. We use cortical graft from the opposite tibia, and there are some papers where they have used graft from the iliac crest as well. The second method is vascularized fibula transfer. This needs to be a teamwork with the plastic surgeon colleagues, where you take fibula and you join the peroneal artery to the anterior tibial artery and peroneal vein to the saphenous vein. And this brings vascular supply with it. You have to excise completely the diseased part and you transfix with screws. And the rate of healing in this method has been reported as high as 80%. So the vascularized fibula is another option. And Elizaro technique is used where they have to excise the diseased segment. You dock the fragment with a frame and you perform a proximal osteotomy, and then you lengthen through the proximal osteotomy. And the rate of healing has been shown to up to 90 to 95%. The advantage of Elizaro frame is you can correct the lengthening or limb length discrepancy at the same time. And the problem with Elizaro is it's difficult to apply in very young children. So those are the issues with Elizaro technique. Now, someone may ask you, what is the latest in the treatment of pseudoarthrosis? And you must know what is 4-in-1 technique. Now, this 4-in-1 technique was originally introduced by Choi and colleagues, which actually mean that the surgery should not be limited to tibia, but you should also try to induce cross union between tibia and fibula, and that will lead to reduced rate of refractures. So they emphasize to induce cross union between tibia and fibula. Later, these protocols have been modified by Rod Paley, and then for Indian subcontinents with the patients with lower strata, this protocols has been modified by our Vadia children's colleagues as well. So 4 parts are important in this 4-in-1 technique. First is the injection of bisphosphonates. Now, we all know that bisphosphonates prevent osteoclastic resorption of the bone. We use it frequently in osteogenesis imperfecta and in some fibrous dysplasia tumors. So in bisphosphonate prevents osteoclastic resorption of the bone, and that allows a higher chance of bone healing. So bisphosphonates are given about a month prior to the surgery or 15 days prior to the surgery. So that's the first thing. The second is resection of pseudoarthrosis, onlay graft from the contralateral sheen of tibia, and interosseous cancellous grafting is done from the iliac crest to induce cross union. So that is another algorithm they have introduced. The grafting is not just around tibia, but it is between tibia and fibula to induce cross union. The stability or the correction of the deformity is done by intramedullary rush rod, and nowadays Fazier dual 3rd generation telescoping rod is done to prevent entry of rod through the ankle and subtalar joint. When the distal fragment is long enough, one can get away with a telescoping nail without violating the ankle or subtalar anatomy. But when the pseudoarthrosis is very low, it is wise to pass the rod through the ankle and subtalar joint. One advantage of telescoping rod is with the age advances, the nail will not become short. In rush rod, we have to exchange the rods time to time as the child's height increases. But in FD rod, it is said that it will grow with the child's length grow. And the final thing is improvising the stability with either an external fixator or Elizaro frame. So these are the 4 parameters of 4-in-1 technique, and there are different papers published. So let's come back to our case. And so at 2.5 years, this boy had this pointing tibia, you can see, and this is the deformity. And what we followed is we did the 4-in-1 procedure where we resected the pseudoarthrosis. We took the contralateral tibial shin graft, divided into 4 pieces, and used it as an onlay graft. We placed some cancellous graft between tibia and fibula. We placed a rush rod because canal was very narrow to accommodate a Fazier dual rod, and we placed a monolateral fixator to provide rotational stability, and we also provided back a plaster splint. And you can see how we put this graft on all the 4 sides of tibia, and we pass a vicryl suture material to keep that cortical graft on the tibia, otherwise it may displace. So that's what we do. And this is at the end of 4 months, we removed the fixator, and you can see there is solid union in the tibia. Fibula has not united, but there was an attempt to cross union, but tibia is nicely united. And with the growth, you can see that the rush rod has migrated distally here, from here to here. And eventually, once the rod recedes near diaphysis, we have to do exchange nailing by exchanging this rod from the calcaneum. Or alternatively, one can put a Fazier dual telescoping rod. And these are the clinical results. This boy, he's having excellent healing, and the ankle, the limb length discrepancy is minimum. So we have to deal with that later. And so from here, we could achieve result. And in most of these 90% cases with this 4-in-1 protocol, the results are same. Now, the next question is, the treatment does not finish here. So what further treatment this child would require? These children require regular follow-up. They need a long-term above knee brace to prevent refractures. So this is very important. We prescribe a hinged knee brace, and they have to make it part of their life, because otherwise they will fracture from the top, and then you have to do something else. And exchange rodding, as I mentioned, when the rush rod becomes short. And finally, the treatment of limb length discrepancy should be done either by lengthening of the affected side or by doing contralateral epiphysiodesis at right time. In this child, the discrepancy is about 1 centimeter. So I feel that this child would need contralateral epiphysiodesis and not limb lengthening. So I think this, if you can learn this and answer all these questions, you must get distinction in your exam. And I wish you best of luck. Thank you very much for your kind attention.
Thank you, Dr. Maulisha. It was really an excellent coverage of the topic, with fantastic clinical picture of the child at different stages. And really, I mean, this was as good as live clinical discussion. It was very, very nice. I mean, extremely thankful to you. And before I go to the other faculty, I would like to ask the opinion. Dr. Lalit, will you like to start the discussion? Lalit?
Thanks, Dr. Maulin. I think, am I audible?
Yeah, yes, Lalit.
That was a presentation worth a distinction.
Thank you, sir.
So you really covered up everything and raised all the questions and gave the appropriate definitions and answers. If the students stick to these, especially the principles you shared, both for treatment and for diagnosis, are the things which the examiner wants to know from a student. He might not know all the procedures in detail, but the principles which are followed. One small question, since I've always asked to ask questions, if you can help us describing how a student should narrate his diagnosis if he gets this patient in exam. Because in a short case, the first question is, what is your diagnosis? So to give a crisp and a complete diagnosis, what should a student narrate when he has this patient?
Right. So that this is a nice question. And I would ask the residents to see in what stage of disease child comes to you. So maybe in earlier on, there must be just bowing of anterolateral bowing of tibia and not a frank pseudoarthrosis. So you must say that this is anterolateral bowing of tibia, probably secondary to neurofibromatosis, type 1, because type 2 is does not have orthopedic ailments. But if the child comes with this Grostek deformity, which came at 2.5 years, and you have an X-ray showing pseudoarthrosis, then you have to say that this is pseudoarthrosis of tibia, secondary to neurofibromatosis 1. Some people, they use this term congenital pseudoarthrosis of tibia. Now, congenital pseudoarthrosis of tibia is a wide term and can be used even for the anterolateral bowing of tibia. So it would not be wrong if they use that term, but I would use that term only when we have an evidence of fracture. If there is no fracture, but just sclerosis of the canal or some cyst without fracture, this is a pre-pseudoarthrosis condition. So it's better not to term pseudoarthrosis. You should term this is anterolateral bowing of tibia, probably secondary to neurofibromatosis 1. Probably is a good thing to say, because someone may ask that, can you differentiate between fibrous dysplasia and neurofibromatosis just by looking at this? Yes, we can differentiate based on Caffeine Spots, but as a level of residence, I mean, your discussion would be diverted to fibrous dysplasia and McCune-Albright syndrome. So better stick to your pseudoarthrosis case and go up to the management part, so that you can score well and you can answer more practical things rather than the theoretical knowledge. So is that what could I answer your question, Dr. Mani?
Yeah, perfect. I think that's perfect. You've rephrased the diagnosis as it comes in a particular patient, and what should be the details. Thank you.
Thank you, Dr. Lith. Dr. Ray, Professor Ray, would you like to add something to?
Usually in such condition, the students will be asked, tell me the other clinical conditions which might be in the anterolateral bowing, particularly in your case. Right. So then what the answer we expect from the students?
Right. So I always feel that students should tell their thinking process. So when you see some bowing or some anterolateral bowing, we sometimes see that in severe rickets, or what's known as a congenital rickets, but there they are bilateral affection. So first differential diagnosis can be a nutritional deficiency leading to deformity of tibia, but that usually would be bilateral. That will not be unilateral. That's one. As I mentioned, that it can be due to a trauma. Sometimes parents have not noticed, and child might have a trivial trauma, and that might have lead to a fracture. So that is another possibility where the child would not bear weight. So that history part and X-ray would delineate. So that will be the second differential diagnosis. And as I mentioned earlier, an infection would present this way when there is swelling or an abscess, which would lead to more anterolateral collection, and that may give a pseudo appearance of anterolateral bowing. So that is one. And besides neurofibromatosis, there are some conditions like osteofibrous dysplasia. This is one of the benign bone tumor, which is, I think, more commoner than neurofibromatosis, and that sometimes osteofibrous dysplasia gives a similar kind of clinical picture, but the radiological findings are more on the cortical. They have more cortical based lesion, and while the neurofibromatosis, mostly it's a more medullary lesion. The same thing can happen in older children. In adolescent, when they come with a painful anterolateral bowing, one has to rule out adventinoma, which is a more painful condition. While neurofibromatosis, or they are not painful, and unless they are fractured, so they are not very painful conditions. So I think these are the differential diagnosis which would coexist in such case.
Thank you, Dr. Molin. And Dr. Rujitra, you are there? Dr. Hitesh?
I am here.
Yeah. Can you, I mean, Dr. Molin has completely covered everything, but is there anything else that you think that the examiner can ask the students, or anything else where, because this is considered a tough case. Let me tell you from the student's point of view. You give them this case, they are very unhappy from the beginning. So
I can add only one. Yeah. I can add only one thing. What Maulin has covered most of the things, but the 40 to 45% of cases, we do not find the neurofibromatosis marker. In those cases, differential diagnosis will come in picture. So whenever the child will present with the anterolateral bowing without any neurocutaneous marker, those cases we can keep the diagnosis, differential diagnosis, like rickets, nutritional rickets, secondary rickets, osteogenesis imperfecta or osteofibrous dysplasia. These are the cases that is commonly asked to the students. And whenever there is NF marker would be there, that is easily you can say I will most likely to be osteogenesis, the pseudoarthrosis, but depends on the status of the patient. If there is no abnormal mobility, you can say anterolateral bowing. When there is abnormal mobility, you can say the congenital pseudoarthrosis.
And Dr. Jayant, are you there? Yes, Jayant. Yeah. Jayant, I'd like to add something more, please.
No, that was very well covered. I think one needs to do a complete physical examination. That is the most important thing, which I feel many students miss, failing to undress the child and look at things like FALA patches. And this is not only among students, but also many practicing orthopedic surgeons. I've seen them actually operating on cases of congenital pseudoarthrosis without ever documenting that neurofibromatosis is also present. So I think that general physical examination is extremely important, even though it's a short case. So not just to focus on the part, but to undress the child completely and examine.
Thank you, Dr. Jain. Dr. Rujuta, you are there?
Yes, I'm very much there. I've been wanting to just say one thing, that it's interesting that Maulin has used a monolateral fixator. Jess is one of my favorite things for a lot of pediatric deformities, but I think this is one condition where even I prefer the Elizaro, as in, you know, when you get lucky and if it's going to unite, it will certainly unite. Of course, it's easier in Jess to see your post-op X-rays and do the monitoring, but really the circular frame stability is very, very superior to Jess in trained hands. So I don't claim to be trained in Elizaro, but this is one instance where I always use my colleagues' help. And when we're doing 4-in-1 especially, I think it's imperative that all 4 things are followed absolutely to the T.
Yes.
Yeah.
Maulin, anything to?
Yeah, so that's right. Especially when the diaphyseal pseudoarthrosis is very easy to use a frame. The reason why we use this, we had frame on our trolley, but the fracture, the pseudoarthrosis was pretty low at the junction of metaphysis and diaphysis. And with the thick rod, rush rod passing through, sometimes it becomes difficult to put your drop wire or your Elizaro wire. And there, to avoid those issues, and with a very small leg of child, sometimes it becomes difficult. But for all diaphyseal lesions, ma'am, we also use now Elizaro frame, especially with this paper from Vadia and from Dror Paley's paper. And one more thing is, like, it's of course not for residence discussion, but now we have started using a neutralization plate also in some children where we are not able to put a frame over when a very small segment. So we have used that, but I agree with that point. And yeah, Elizaro frame has better stability.
The other point is there is a condition called congenital posteromedial tibial bowing, which is the opposite of anterolateral bowing. And I have seen the two of them being confused very frequently, except by experienced pediatric orthopedic surgeons. So this is exactly the opposite way, and congenital posteromedial tibial bowing should be differentiated. So you might be kept a congenital posteromedial tibial bowing case, and that has a completely different natural history and treatment. So you should not confuse the two. And both happen present in early childhood between the ages of 1 and 5 years. So it's important to keep those two things.
Jayan, can you briefly say the treatment of congenital posteromedial bowing? That is very important.
So congenital posteromedial tibial bowing is a benign condition that largely the deformity itself resolves by the age of 5 to 6 years. But many children are left with a leg length discrepancy. And leg length discrepancy typically in most cases can be managed with a shoe raise because the discrepancy at maturity is less than 2 centimeters. Some children may need contralateral epiphysiodesis, and in very rare cases, one may need to do lengthening of the short limb. So I think as students, please read the two, anterolateral bowing and posteromedial tibial bowing, both of them together, so that you clearly understand the clinical differences and the treatment differences between these two conditions. They are easily confused.
That's true.
Hitesh, anything more you'd like to add?
Yeah, that the difference between the anterolateral bowing and the posteromedial bowing is the apex. The apex of the bow is anterior and lateral in the congenital pseudoarthrosis or anterolateral bowing, where it is totally opposite, posterior and medial. Okay, I don't want to add one more thing, otherwise third bowing would be fibular hemimelia. But then it will become really very complex, where it is the bowing would be anterior and medial. So anteromedial bowing would be present in the case of fibular hemimelia, and it would be associated with the shortening. Okay.
So just
this all three.
Yeah. So just one more thing I would like to add. I have seen few cases of isolated fibular pseudoarthrosis, and they have kind of type 2 in tibia. So there might be some cystic changes in tibia, but tibia has not fractured yet. And people, they apply the trauma principles in getting this fibula united. They break tibia from the site where you see the cyst. And those, now there is a double problem. So the fibula is not united and tibia would also fail to unite. So whenever you see non-uniting fibula, so isolated pseudoarthrosis of fibula is also an entity. Do not fracture the tibia, because sometimes the neurofibroma must be lying within the tibia as well, and then patient would end up in disaster. So I think that's what I wanted to say.
One question, Dr. Maulin. What Rajita was asking about the ring fixator. Will there be an age limit that where below that you will not consider a ring fixator?
Well, we had recently discussion with Sandeep Vaidya, who was the first among one of the authors of their paper. And I tend to apply ring fixator after 4 years, because I find that size is enough to put the ring and wires. The another thing is the size or the site of pseudoarthrosis. If it is in the mid diaphysis, we can put the ring fixator easily, because the rods, we have space around the rod in metaphysis. But when you have very distal pseudoarthrosis, then it's difficult to put the Elizaro frame. But as I know that some people, they have started applying before 2 years. The problem is when child's leg is very small and where there are so many rings, it is always difficult to assess the union of a pseudoarthrosis. We'd like to take AP lateral oblique views to see the 4 cortices, and we think that when 75% of the cortice is healed, that's a real healing. So sometimes we need to take 3 views, and it becomes difficult to visualize those all the cortices with the frame. No, that's one more problem. Of course, stability is most important thing here. The third thing also is we have to retain the fixator till we see some radiologic sign of union. And in some cases, it may take up to 3.5 months for having, visibility of union. So the question would be to retain that frame for 3.5-4 months without having any skin infection and all. That becomes sometimes difficult. So that's why my take is to use a unilateral fixator, and sometimes we give a back slab to add some stability in younger children. But for older kids, of course, Elizaro is a better way to use it than a monolateral fixator.
Thank you, Dr. Maulin. I think, Ray, you want to say something? Or?
Yeah. One thing is that amputation is one of the treatment in some failure cases, repeated failure. What actually be the criteria, or in what are the criteria that I will think of amputation in the ring?
So, I mean,
that will be asked.
Yeah. So I feel that I have never suggested. The key thing is when there are multiple attempts of union has failed, then one would embark on amputation. Now, though But with the good success rate of this, we see the success rate of rodding and grafting up to 90% with second bone grafting session. We see with Elizaro, it's almost 90%. Now we see there's with the vascularized fibula and 4-in-1. Now 4-in-1 with this Vardia series with Dror Paley, they have achieved almost 100% union. So we have seen a couple of cases in our foundation where the whole tibia was having neurofibromatosis, and Dr. Alvin Crawford visited us, and we did a McFarland like bypass tibia. We did multiple surgeries, and we did not it did not unite. And we saw that case to Dr. Crawford and said, this child has failed 4 previous surgeries, and parents are saying that we want a final solution now. But he said, you don't amputate the limb, you excise the whole segment, and you put a fibula graft, get it vascularized. So amputation in current today's day, I think is not an option. I mean, I have never described as one of the option. Jayant, Hitesh and Rujuta, what do you say about it?
I have seen a couple of amputations, and I feel that it is a decision that has to be left to the family. In fact, both of the cases that I encountered, I did not conduct the surgery, but I saw them subsequently during follow-up because of some problems with limb overgrowth. One of them was in the UK and one was in India. So in both cases, multiple failed surgeries, and a lot of functional disability and a huge leg length discrepancy, which I don't feel by any means would have been successfully treated. Surprisingly, the parents were very happy because they had had such a torrid time of several years of repeated lengthy and complex reconstructions that had significantly disrupted their life. So the minute they got an amputation, and it's a BK amputation, children do extremely well with it, and child was back walking and running, and they seemed extremely happy with that option. So I don't think, I mean, as far as possible, I agree with you that with the modern techniques available to us, amputation is really completely a last resort. Still, I think in very, very rare cases, I think one can keep it in the back of one's mind. But it is a last resort.
Thank you all. I think we have taken half an hour more than what we permitted. Jayant, I need a little favor from you. I had completely forgotten. When I formed the program, I had promised Hitesh that he has to go for around 7 o'clock. I will spare him. So would you allow me to small help by permitting Hitesh to finish his presentation?
No problem.
So thank you very much. I'm sorry I would have to leave, but I enjoyed this session and discussion.
Thank you, Maulin. We are going to miss you because I really wanted you to be there, but I know you have a program. And if possible, next week, join in at least for a short time.
Sure.
Okay? Thank you. Thank you. Dr. Hitesh, please think. My apologies to Dr. Jayant. Hitesh, please carry on.
Yeah, I am sorry, Jayant. I am extremely sorry, but I have to join one more meeting. Okay.
No, you had told me, so it's my thing. I should be.
Yeah, no, can you see the slide, sir? Ron?
Yes, visible. It is visible.
Okay, fine. Thank you. Good evening to all. Thank you very much for giving this opportunity. I will share my experience with the Cubitus virus. The Cubitus virus is very commonly kept the exam case for the postgraduate, in contrary to the cold pediatric orthopedic cases, because it is following a trauma. And the most of the postgraduate would be aware, and it is very commonly asked, what is the reason? The 90% of the cases of the Cubitus virus due to the malunited of the supracondylar fracture of the humerus in a child. Then the question is there, why we need to discuss the Cubitus virus, such a simple case? The important aspect of the case discussion is there to find out the complication of the Cubitus virus, associated or differential diagnosis of Cubitus virus, and the treatment management, how would you approach this child? That's why the case would be kept in an exam. Otherwise, if you say about Cubitus virus, the commonest cause is malunited supracondylar, and the treatment is also very simple, the French or modified French osteotomy. So I will discuss in a brief what the examiner wants from the students, postgraduate students, for their final exam. The commonest question it is asked is, what is the diagnosis of this child? What will you do for this child? Why you chosen this option? And how would you do? These are the 4 commonly kept the answer in a very short case. And very commonly it can be start like that. But some of the examiner do not progress like that. They want to have the history, clinical examination. So I will go on the actually regular case, how you can present the case from the history, look, feel, move, and measure. Then we'll discuss few of the points, how to have diagnosis, what are differential diagnosis, what will you do for this case. So the Cubitus virus diagnosis by the history and examination, what are the important or silent points on the history? It's important to have the age of the child, very common to have the supracondylar fracture between the 4 to 7 years of age because of the anatomy of the distal humerus. Commonest mechanism would be indirect on a non-dominant hand, that is a fall on outstretched hand. If there is chances of the child is having direct injury, there is a flexion type of supracondylar. The handedness of the child would be very important. The 2 importance, a non-dominant hand will have the injury of supracondylar, and it will be useful for the functional limitation of a child. Very common to have the inadequate or the incomplete treatment in the rural area, or the treatment would be by a bone setter, and that when give a positive points in a history that may be a malunion of a supracondylar fracture. Always ask the history of the massage. If the history of massage would be present, you can suspect about the myositis ossificans around the elbow. And in that sense, always pay attention for the range of motion of the elbow joint. If it is restricted, think about the myositis ossificans. The non-progressive deformity, always ask the deformity nature. If it is a non-progressive, always it would be malunion. If the deformity would be a progressive, it will give you idea about indirect injury of the physis. So whenever there is a physial injury, it will be a progressive deformity. Or second cause of the progressive deformity is the avian trochlea. Okay, so always remember these are the important in the history. And never forget to ask that what the patient wants, whether it is a cosmetic concern or whether it is a functional concern. So these are the very important points we need to ask for the child. And what the examiner wants also a complete detailed history in a short case. Coming to the examination point of view, it is quietly visible. It's a gunstock deformity. It is very well visible on the front, on the look. But I urge the postgraduates, many of times they forget the basic principle. The Cubitus virus is only and only, but the carrying angle is only and only visible or measured when the elbow is extended, forearm is supinated. So if it's a child may not able to extend the elbow or it cannot supinate the elbow, don't say it's a Cubitus virus. Many of time, because of the internal rotation of shoulder, that would be the apparent Cubitus virus, or there will be elbow flexion deformity. It would be apparent Cubitus virus. Do not get confused with the Cubitus virus, which is actual Cubitus virus, or that may be apparent Cubitus virus. Second important point on the look, always see about the cubital fossa from the front to see whether any mass would be present. In case of the mass would be there in Cubitus virus, that will be common in the brachialis muscle due to the myositis ossificans. These are some of the clinical pictures we'd be having in apparent Cubitus virus. It's not actually Cubitus virus, but it's because of the flexion deformity of this. And right side, we can see it is the radial head is dislocated. We can see it's a prominence that is also very, very misleading. Another aspect, as I said, that is because of the internal rotation of the shoulder. So don't get confused with the apparent Cubitus virus. The another point, whenever you can have the bony prominence all over the body, that is not in the traumatic condition, but the cold condition like a hereditary multiple exostosis or the dysplasia of the upper limb, that the hand would be deformed and it would be present like a Cubitus virus. That's why it is important to ask the fall on outstretched hand or the history of trauma. this Cubitus virus would be present without history of trauma. So I'm talking about the traumatic Cubitus virus. The fourth important point, by the look, you can see the difference in the both child. The right side is severely short. So where the Cubitus virus is there, it would not be appropriate to have a severe shortening in case of the Cubitus virus. Whenever you will see the severe shortening in a child, that may be something else than the malunited supracondylar of the humerus. It is the case of the skeletal dysplasia, hereditary multiple exostosis would be present, but they may present like that. The important examination from the side, whether the elbow is straight or hyperextended or a flex. As I said in beginning, Cubitus virus or the carrying angle is only measured in elbow is extended and forearm is supinated. Always check that in the lateral position. What is the inspection from the back? You can see from the back the patient has got the left Cubitus virus, but it is in a flex position, in an extended position, it is the same or not. And another important point from the back side is the prominence of the olecranon process. If the olecranon process is prominent, that will give you the indirect clue might be patient having the old posterior dislocation of the elbow. And that would be one of the differential diagnoses. That is not only one, but you have to keep in mind, because examiner will ask what need to check from the front, what need to check from the side, what need to check from the back. Coming to the palpation, what need to check? They always start with the tenderness, and most of the time, all the deformity would be non-tender. But somebody is going to ask where to check about the joint. You can see about the joint line. You can see above the joint and below the joint. And the most important aspect of the palpation is the same bony prominence. Start with the medial and lateral epicondyle and go proximally, palpate the supracondylar ridge on medial and lateral aspect. In case of the recent trauma within 6 months to 12 months, you can palpate about roughening and thickening of the supracondylar ridge where there will be fracture and it will be united. So you will not palpate any step or a gap, but you will palpate the thickening and roughening of supracondylar ridge. If it is present in ulna or radial head, that will give indirect clue of the old fracture. That's why always see about the or feel about the all the bony prominence around the elbow. The most important and the postgraduate examiner will ask the most favorite is 3 bony relationship. What are the 3 bony points? Medial epicondyle, lateral epicondyle, and tip of the olecranon. In case of the extension of elbow, all would be forming one line. So you can see in the picture above, it would be straight. But in case of the flexion, they will form about triangle, but that is not isosceles triangle. It will be difference between the medial side and lateral side. But the important aspect you need to compare to the opposite side. Why this is important? If the injury above this triangle and below this triangle, the triangle would be maintained. Injury between the triangle would be distorted. So commonly kept question is there, what do you mean by 3 bony relationship? If the triangle is maintained, that will indirect clue of the supracondylar fracture. If the triangular relationship is 3 bony point relationship is not maintained, that may be the injury to one of the condyle, that may be injury to the olecranon, or commonly differential point between the posterior dislocation of elbow. In case of the supracubitus virus, supracondylar fracture, it will be maintained. Then the important clinical examination would be move. Always check about the start with the joint movement, the adjoint elbow, one joint above and one joint below. Elbow joint is a flexion and extension. Shoulder joint, radial ulnar joint, and a wrist joint. Why it is very important? The examiner, the range of motion is the important aspect of the clinical examination, because most of the child will have the hyperextension injury and the extension would be exaggerated while the flexion would be restricted, and that may be due to the hyperextension malunion in case of the children, and terminal flexion would be restricted. Whatever hyperextension would be there, terminal flexion would be restricted, and you can say that that may be the malunion in the sagittal plane. The arc would be maintained. What of caution? Whenever the restriction of range of motion is there, think about something else other than the malunion. It may be there in case of the myositis ossificans or the intra-articular injury. Don't say about lateral condyle or medial condyle. That might be injury inside the joint, because joint stiffness would not be present in case of the supracondylar uncomplicated case. It may be present in the complication of the supracondylar like myositis ossificans. So in case of the restriction of the extension, the examiner will ask which are the cases. As I said, it is an intra-articular injury, maybe the olecranon fracture, one of the condyle fracture, or the coronoid fracture. Or it may be the joint injury like a old dislocation elbow joint, or maybe the extra-articular case where there is a myositis ossificans. Difference between the myositis ossificans and that other injury, we can have a palpable mass present on the brachialis in case of the myositis, where it will be absent in all other injury, if somebody is going to ask that. Second commonest question would be asked, why need to examine the shoulder joint? Because there will be lack of remodeling potential at elbow. The internal rotation would be the very, very different. It would be different than the opposite side. Internal rotation would be exaggerated and external rotation would be restriction. We can see that in the left side and right side, the external rotation would be different than the right and left. Similarly, the internal rotation on the left side would be more. So internal rotation is more and external rotation is restricted. We can say it's a rotational malunion. Rotational malunion component, very common in a posteromedial displaced fracture of the supracondylar. So if shoulder joint would be examined, always examine the range of motion in rotational plane. Then coming to the points for the movements for the radial ulnar joint. Why need to see about radial ulnar joint? Because if rotation of supination or pronation would be restricted, we can give idea about something pathology at the radial ulnar joint. Okay, radius or ulna or malunited montage would be present. Why need to check about the wrist joint? If the manus varus or manus valgus deformity would be there, range of motion of the wrist would be limited. And that will give you the clue it is not a post-traumatic cubitus virus due to the supracondylar fracture. And this is the one of the child where it's presented like cubitus virus. Because I specifically got this case for the teaching purpose, the child has got restricted supination and pronation. It is the gap non-union of ulna due to the infection. And it will, if you see that, it is exactly present like a cubitus virus. So be aware about this complication in case of the exam. Sometimes we may get the surprise in exam. Coming to the measurement, what to measure to see about the acromion to tip of the lateral epicondyle, it is decrease in malunited supracondylar, while the tip of the epicondyle to the wrist joint or tip of the radial styloid will decrease in posterior dislocation elbow or pathology of a radius and ulna. The intercondylar distance would be compared to the opposite side in very rare case of the intercondylar extension, but it has to be measured compared to the opposite side. The vesting of muscle will give out a long-standing chronic history, but in case of the most of the child will not have the vesting. But if it is there, you think about something infection or other pathology. Common question is that how to measure about the carrying angle. We need to draw about line of the forearm and line of the arm. We need to take about anterior axillary fold and the deltoid and take about the center point of the cubital fossa. And similarly, both the styloid process in ulna and measure the normal carrying angle is how much, and it has been taught for the undergraduate. It's very simple. Never ever miss about distal neurovascular status, because many times it will be palsy or the old Walkman ischemic compartment. That is Walkman ischemic contracture would be there. So always check about that. Coming to the final diagnosis, how to describe about final diagnosis, we can describe the post-traumatic cubitus virus, which is left side or right side, very common to have left side due to the malunion of the supracondylar fracture. The commonly asked the question is there, which component will have malunion? If it is a sagittal component would be there, that would be hyperextension would be present with the flexion is restricted. If it is rotational component would be there, internal rotation of the shoulder would be more than the external rotation. External rotation would be restricted. Commonest question would be asked to the postgraduate would be, how would you justify the cubitus virus due to the malunited supracondylar? We can say the age between 4 to 7, the fall on outstretched hand. Fracture of the distal humerus is very, very common. The not treated or inadequately treated and non-progressive deformity. by the examination point, it will be Cubitus Virus. 3-point bony relationship is maintained. Irregular or roughening and thickening would be present in supracondylar ridge. Internal rotation would be more, and external rotation would be restricted at shoulder. The flexion would be restricted, that is terminal flexion, and extension would be exaggerated. These are the points would be answered in case of the postgraduate exam. What are the rare causes? Very commonly, when it is not fitting in one of them, that will be rare causes distal fascial arrest, but it will be different that it is a progressive deformity, but it is very slowly progressive because distal end of humerus is not growing hand. The malunion of lateral condyle, very, very rarely it will be present, don't utter in most of the exam, unless there would be 3 bony point relation is altered, and that is only roughening present on the lateral aspect. Malunion of ulna, yes, it will be also present, but the clinical finding would be roughening and thickening would be there in ulnar side and associated with the radial head dislocation. Very uncommon to have malunion of the medial condyle. It will be associated with the restriction of range of motion. The next question would be there, what will you do for the case? Will the common answer is that take the full length X-ray of the elbow, AP and lateral. For the postgraduate, why we need to take about X-ray? Because many examiner will ask to diagnose whether it is Cubitus Virus due to the malunited supracondylar fracture, to detect the complicated case like myositis or any other things like the avascular necrosis of the trochlea, severity of deformity we can measure, and do about the planning of treatment, where to do about osteotomy. The important aspect of the elbow X-ray reading is there. I urge the postgraduate to remember the credo, C for capitulum, radial head, interepicondyle, trochlea, olecranon, and lateral epicondyle. I will come to that point in 2 minutes. But rule is that 2, 4, 6, 8, 10, and 12. It's very easy to remember how ossification center around the elbow which appears. Okay, very commonly we can see about the child present with the Cubitus Virus, which is very uncomplicated. It's because of, we can see this case of the malunion of the supracondylar fracture on the left side of the screen. If you see on the right side of the screen, this case is also present like a Cubitus Virus, but what difference on the left and right side of screen, where here the ossification center of the olecranon is present, ossification center of the lateral epicondyle is present, but olecranon ossification center of the all around the elbow is present, but ossification center of the trochlea is missing. And this is the complicated or a complex case of the Cubitus Virus. Why it is important to understand that this is a slowly progressive deformity, and if you do about the very early osteotomy, it can recur. And that is the reason that many of the examiner will ask, when will you do about correction? You know that the coronal plane deformity is not going to remodel. So then why need to wait that? Sometimes it is better to wait to see whether it is a progressive or non-progressive. Second, we can see about ossification center of the trochlea, whether it is present or not. If it is getting delayed or not present, think about some complicated case. Again, yes, I said radiological examination of the radius and ulna would be important because sometimes you may get the surprise. So what will you do for the case? In that, again, lateral X-ray is to find out whether it's a uniplanar, biplanar, or a triplanar deformity. The anterior humeral line should pass through the capitulum. It is not passing. It is present is a hyperextension injury. When you're planning about treatment, you can correct all triplane deformity. Then commonly question asked that how would you do about the deformity planning? You can do about longitudinal axis of the humerus and elbow joint and think about how much deformity would be present. Then you can think about the wedge. The common treatment would be the closed wedge osteotomy and dome osteotomy. I'm not going in detail about the closed wedge osteotomy, but lateral closed wedge osteotomy is very commonly performed and it's been described by the French and modified French. I'm not going in detail, but one point I will take that if you do only the plain, the lateral closed wedge osteotomy, it will be commonly asked to the postgraduate, what is the complication? The most common complication is there is a lateral part of the distal humerus would be prominent. The cora, the center of the rotation would not be at the supracondylar. If you do the osteotomy just above, we need to do about the translation. So medial translation in order to avoid the lateral prominence. And that is the reason many times many examiner will ask, what will you do about the osteotomy? You can do the lateral closed wedge osteotomy with medial translation. Another osteotomy, you can correct about the triplane osteotomy by the dome osteotomy. You can calculate about the dome and correct about dome. You will not have the lateral prominence at all with the dome osteotomy. Another advantage, you can correct about the biplane or a triplane osteotomy. Fixation, yes, fixation can be done with the K-wire, screws, wire, external fixation or plate and screw. This is a child present with the Cubitus Virus, treated with the cross K-wire. It can be treated with the 2 lateral wire or a cross wire. It can be treated with the French osteotomy or a modified French osteotomy by putting about 2 screws and SS wire. Or in the adolescent or near adult, you have to treat with the fixator to have a strong fixator. I will finish my talk with the last point on that. Somebody is going to ask, because the last exam, some co-examiner, external examiner asked that, would you do with the growth modulation, because it is very, very recent advances in pediatric orthopedic? The answer is say no, because it is not a distal end of the humerus is not a growing end. So the growth modulation would not be very effective in case of the distal humerus. Then which case we can do about the growth modulation? When the deformity would be progressive, when you will have the one side growth arrest. In those cases, after correction, we can keep about the growth modulation in order to prevent the progression. I'll stop here. Any question, I'll welcome. Thank you.
Thank you, Dr. Hitesh. It was excellent. I think you have probably covered completely everything, and that too in a very simple but very easy to understand for the students. I think that was very, very nice. It's a very common case at the postgraduate level, undergraduate level, MS, ENB, everywhere it's very common case. Dr. Rujita? Dr. Rujita?
Yes, sir.
Yeah, anything like to add on to that?
So I think Hitesh has really been very, very succinct. Just 2 more things I would want to say. One is, this is a very common case in exams. So what the PGs need to remember is that you're not forgiven for not knowing the basics and not knowing at least the common approaches. It's okay if you don't tell us about the step cut osteotomy or a different what approach you will use or what is the preferred at your center, but you have to know basic evaluation, anatomy, and some differentials, and what would be the line of thinking. And the second thing that I wanted to say is that trochlear AVN is not really easy to diagnose. Whenever in doubt, for an expert like Hitesh, he would really go around looking at the ossifix centers. But whenever in doubt, for the PGs, it's safer just do a comparative X-ray of the other side, because the God has given us 2 limbs for comparison. So if you see really something that is not really matching up to that, then definitely suspect in very severe Cubitus Virus cases trochlear AVN.
Thank you, Dr. Rajita. Dr. Jayant? Jayant?
No, I think Hitesh has really comprehensively covered everything. So nothing further to add, really.
Yeah. Dr. Ray, anything you would like to add to that? Any questions or any comments?
Actually, he has covered almost everything. But one question, very common question is asked to the students, that how long should we wait after supracondylar fracture for correction of the deformity if it arises? Number 1. And second thing is that very often we get the flexion block, restriction of flexion. What are the causes of flexion block, and how do you diagnose it clinically? These are the common questions we ask, isn't it? That is the end fill. Sir, you can cover that.
Yeah. Regarding the first question, when should we treat the child? If child present very early, we do not recommend the surgery. The reason is that when the child has got, it is the angular deformity and the rotational deformity around the elbow is not going to remodel. By some extent, the sagittal deformity, at the most of the sagittal, because it is on plane of the range of motion, it will remodel. So as you are right, very commonly asked the question, which deformity will remodel, which deformity will not remodel. So they must learn that rotational and angulation cannot remodel, but sagittal deformity will remodel. Second point, there is a translation deformity. If there is a translation deformity, that will remodel completely, even in coronal plane. Translation deformity, we need not to go and jump and do the osteotomy. And that is the reason I generally recommend the osteotomy after at least 9 months to 1 year, because the child have got a remodeling of bone, not remodeling of deformity. So the answer is there, we will wait irrespective of the child. And second, the child's bone should be adequate enough or big enough to hold the wire and fixation. That is the two reasons. We will wait up to the 9 months or 1 year at least. Sometimes we will wait little longer in order to find out whether it is a complicated or uncomplicated. Because if the patient says or mother, father says, if it is a progressive deformity, I will like to wait it. I don't want to jump and do the osteotomy very early. Okay, second part. The second question about the flexion restriction.
Block.
Yeah, it is, if it is the sagittal plane malunion, very commonly the terminal flexion would be restricted and there is a hyperextension would be present. So if there is a hyperextension and terminal flexion is restricted, if it is a non-dominant hand, a child is not using for the eating purpose or any other purpose, then we will evaluate the child in a functional status. So the ideal answer would be the see about the functional status, because the most of the 15 to 20 degree of the flexion restricted will get remodeled in sagittal plane. So that doesn't require correction. But yes, if it is associated with the Cubitus virus, we tend to correct on a both plane. And the recent literature in Journal of Pediatric Orthopaedic, there is a sagittal plane range of motion also can be corrected with the sagittal plane osteotomy. Because if there is a gross restriction not reaching about a 90 or it's just reaching to about 90 with functional limitation of range of motion, it will require about the correction.
Thank you, Hitesh. Last, Lalit, any comments?
Yeah, Dr. Hitesh, that was an excellent talk. I take the elbow examination talk very regularly, and I see you have covered it to a great extent. Two questions I have. One is, do you expect the student in an exam to draw the long axis of the arm and the forearm to evaluate the magnitude of the deformity? And the second is, at times the students get entangled into what is the definition. So what definition is acceptable, meaning what is Cubitus Virus and what is physiological and what is Cubitus rectus and valgus?
Yes, it is an excellent question, sir. Thank you. It is very commonly asked by some of the examiner. I generally do not insist about the lines, but some of the exam, because I was a co-examiner with my next examiner asked, that's why I have included those lines, because it would be asked. That is the reason I have included in talk, because most of the postgraduate will be fumbling that from where we can get the reference. That one line between the anterior axillary fold and deltoid, the center point of that. And second point is center point of the cubital fossa. And the third point is center between the both styloid process. So it is not mandatory to draw the line, because it is actually the short case. They may not have time. But if the examiner asks that, they must know about that. That will be a reason. And the definition of the cubitus, that's carrying angle, the carrying angle would be more in case of the female than the male. And the carrying angle, then there is a disappearance of the carrying angle, or it will become straight. It is called as the cubitus rectus. It is straight is cubitus rectus. It is when the arm and forearm axis is straight, it is cubitus rectus. When the arm axis is laterally, and that is the forearm is deviated medially beyond the 0 degree, it is Cubitus Virus. And it is always to be compared to the opposite side.
Opposite side, yeah. Thank you so much. Excellent.
Thank you, Hitesh. That was a very nice listing. And Hitesh, just to because you might be leaving now. If there are any questions from the audience, which will come later, we'll inform you and then we can give you an answer in the next week. Okay? Thank you, Vijay. Thanks so much.
Thanks.
Dr. Jain,
Thanks, sir.
I'm so sorry for the delay, please, sir. And by the time Jayant is sharing the screen, this is to the students. This particular topic, I specifically asked him, I wanted him because this is something you all should know, not only from the exam point of view, that is something where you must treat the child. It's very, very important. Dr. Jayant, please carry.
Oh. You can see my presentation.
Yeah, we can see you.
Okay, great. So crouch gait is an important exam topic. It has been asked several times in the theory paper. And if you do get a case of cerebral palsy, it's more than likely to be a child with crouch gait because older children with CP typically have crouch gait. So I'd like to thank Dr. Dhiren Ganjwala, who is president of POSI, for some of the illustrations. So before we rush into crouch gait, it is good to look at some basics of cerebral palsy management. Every student must know this, the Gross Motor Functional Classification System, or GMFCS. This is the single most important and widely used classification system for children with cerebral palsy. We also have the topographical classification, hemiplegia, diplegia, etc. And we also have the functional classification based on spasticity, dystonia, etc. But GMFCS classification is the most important system we use now. There are 5 levels. Level 1 is the child who walks without any limitations. Slight limitation is level 2. If the child uses a crutches or a walker, it's level 3. A child who can walk with support but largely is in a wheelchair is level 4. And a child without head control is level 5. And the problems that children in each of these levels have is different. So always classify any child with CP according to this first. The next is the concept of diagnostic matrix, which was introduced by Dr. John Davids from Shriners Hospital in Sacramento. Too often we tend to rely on either history or physical exam or some other modality in order to make our decisions. And frequently this is a source of error in decision making. So Dr. Davids introduced this concept where we use all of the modalities: clinical history, physical examination, observing the child walk either with the naked eye or using 2D videos. We also use various diagnostic imaging tools. We use 3D gait analysis. And in cases where there is a doubt between spasticity or true muscle contracture, we can even examine the child under anesthesia to differentiate this. So we take all of these modalities into account before reaching a decision regarding any particular child. As is often said in cerebral palsy, decision is far more important than incision. The other basic concept you need to understand is this Graham and Roda classification. This divides children with diplegic CP into 4 different categories based on their sagittal gait pattern. So this is watching the child walk from the side. So group 1 is a child who is in true equinus. So the ankle is in equinus, the knee and hip are straight. Group 2 is the jump knee gait, where the ankle is in equinus, but it is associated with knee flexion, but the pelvis is reasonably level and there is no excessive flexion at the hip. Group 3 is an important group. It's called apparent equinus. So here, the ankle looks as though it is in equinus, the heel is off the ground, but the ankle is actually at 90 degrees. And the reason for the equinus appearing ankle is because of knee flexion. So here there is no problem at the ankle, but there is an appearance of equinus, and the true problem is at the knee. It's at the hamstring and quadriceps level. And group 4 is the topic that we are going to deal with, that is crouch gait. And here you have hip flexion, knee flexion associated with either a neutral ankle, an ankle is at 90 degrees, or there could be excessive dorsiflexion at this ankle. So it's very important to classify children according to which sagittal gait pattern group they belong to, because the management of each of these groups is different. The other concept about these sagittal grade patterns is any particular child with CP could go through all of these groups. So you have a 4-year-old, the same child at 4 years could be walking in true equinus. And then by the time they are 8 years, they go into group 3, apparent equinus. And then by the time they are 13, they could go into group 4 or crouch gait. So the same child could move to different groups. So when we describe a child with cerebral palsy, the first thing you have to say is what is the GMFCS level? And if the child has diplegia, the next thing you have to say is which particular group they belong to. So crouch gait, as I said, describes a child who has excessive knee flexion during the stance phase of the gait cycle. And different authors use knee flexion in excess of 20 or 30 degrees as a basic criterion. This is associated with excessive hip flexion. The ankle could be in neutral, it could be at 90 degrees, or it could be in excessive dorsiflexion. Importantly, there are associated deformities in the transverse plane at the femur, the tibia, and the foot, and we will look at these in more detail in the talk. So why is crouch gait? So why has crouch gait been asked 10 times in the exam and jump knee has not been asked even once? So there is a specific reason why crouch gait is important, because it is the most serious and worrisome gait pattern in CP, according to Jim Gage, who is a very well-known CP surgeon. It is progressive and eventually it will limit independence of the child. All grades of severity of crouch, therefore, need to be actively managed, because if you don't actively treat it, it will progress in severity. And iatrogenic causes are very common. Surgeons, unfortunately, because we did not understand CP so well in the past, we have caused many children to go into crouch gait due to poor decision making. So as surgeons, we need to be aware how not to contribute to crouch gait through our treatment. So etiology of crouch previously used to be thought of as just tight hamstrings, as a tight hamstring, and many of these children just used to receive hamstring releases. Now, thanks to modern treatment methods, musculoskeletal computer modeling, gait analysis, etc., we have a much more comprehensive understanding of what are all the etiological factors that together contribute to crouch gait. The most important factor is anti-gravity muscle weakness. There are 3 muscles that keep us upright: the gluteus maximus, which is a powerful hip extensor, quadriceps, which is a powerful knee extensor, and the gastrocnemius, which is a plantar flexor. So these are the 3 main muscles that help to hold our body against gravity. The other unseen factor, which is playing a role in our walking, is the ground reaction force. This is the Newton's third law. Every action has an equal and opposite reaction. So when you stand on the ground is applying an equal and opposite force to your body, and that's what's keeping you upright. And the direction of this force is very important for you to have efficient gait. So at initial contact, the ground reaction force goes posterior to the knee, but due to the action of soleus, that ground reaction force goes anterior to the knee. And this change in the direction of the ground reaction force itself causes the knee to go into extension. And it's an important mechanism by which the human body normally is able to become more energy efficient during walking by using the ground reaction force to our advantage. In children with CP, they are not able to use this ground reaction force to their advantage, and that causes many of their gait impairments. So this is a diagram illustrating what the ground reaction force is doing at initial contact, at heel strike. But by the time you get to mid stance, because of eccentric contraction of the soleus, the knee is pulled back and the ground reaction force goes anterior to the knee. And when the ground reaction force goes anterior to the knee, the body is able to use the static posterior restraints of the knee, the posterior capsule, etc., in order to stabilize the knee without expending additional energy. And this is called sometimes the plantar flexion knee extension couple. And this is an important natural mechanism that we have, which helps in energy conservation. So what causes muscle weakness? So we understood that there is muscle weakness in these anti-gravity muscles. So natural history of CP and locomotor neuron lesions like polio and spina bifida. CP is not the only diagnosis that results in crouch gait. Crouch gait can also happen in other neuromuscular conditions. So the natural history of the condition itself may cause progressive muscle weakness. And then we have this principle called law of magnitude. What is law of magnitude? Muscle strength is proportional to its cross-sectional area. And that's, as we know, cross-sectional area is pi r squared. Muscle weight or volume is proportional to pi r cubed, pi r squared h. So a child who is 9 doubles their weight as they go through adolescence. So if you double the weight of a muscle, the strength of the muscle goes up four times, pi r squared, but the weight of the muscle goes up 8 times. So as we become bigger from children, as we go into adolescence and become adults, our muscles become naturally weaker. And this is a fundamental principle of physics that we cannot avoid. It happens to all of us. But in normal children, there is sufficient reserve capacity that we are able to continue walking. But in children with neuromuscular disease, when already they are at their peak or they're using most of their muscle strength, when they have a big growth spurt, they decompensate and have gait disturbances such as crouch. Iatrogenic weakness is another important factor that causes children to go into crouch gait. 1 centimeter of excessive soleus lengthening is supposed to cause a 50% reduction in plantar flexion power. So even a very minor surgery, such as a percutaneous tendo-Achilles lengthening in a child with diplegia, can cause them to lose significant amount of anti-gravity power. And in many series, 50% of children who have crouch gait in the teenage years have had some sort of calf lengthening surgery in early childhood. So we must try and avoid calf lengthening surgery in children who are very young with cerebral palsy. Short muscles we all know about. It's the hamstrings and the iliopsoas that are short in children with crouch gait. But one important point of caution is that hamstrings can be excessively long or they can be normal in crouch gait. And this is again 3D musculoskeletal modeling that has shown us that you can have excessively long hamstrings in children who walk with crouch gait. In those children, the main problem is muscle weakness, not muscle shortening. Only 60% of children with crouch gait actually have short hamstrings. So it's important to not just lengthen the hamstrings in all children with crouch gait, because that may not always be the problem. And the shortening of the psoas and the hamstring in turn causes secondary hip and knee flexion contractures. The other concept I would like to introduce to you today is this lever arm dysfunction. So what is lever arm dysfunction? It's an important cause of gait abnormality in cerebral palsy. The levers in the body are our bones and joints. Lever is nothing but a simple machine that converts a force into a rotation. The commonest lever that we use is a door. We know that the handle of the door is placed well away from the hinge so that you get a large moment arm, and this improves efficiency. If you put the handle very next to the hinge, you have to apply a lot more force because you are reducing the lever arm. So this is a concept that we are all familiar with. So the longer and stiffer the lever, the better the mechanical efficiency. Equinoplanovalgus deformity or midfoot breach is a very common deformity that we see in the foot in children with diplegia. Let's look at what happens to the mechanics of this child. So if you have a rigid lever, when you apply a force on one side, all of that force is transmitted to the load. But if you have a flexible lever that is bending as you apply the load, then not all of your applied force is actually results in work done. And that is exactly what happens when you have a planovalgus foot. So here is an illustration. The green arrow is the soleus, which is contracting to cause push-off. The red arrow is the body weight, which is pushing down. And you have a very powerful lever with an intact medial longitudinal arch that allows transmission of force in an efficient way so that you can push off. So we are not only dependent on a strong lever, the medial longitudinal arch, but we are also concerned about the length of the lever. We want as long a lever as possible. In a planovalgus foot, that rigid lever becomes a flexible lever. So not all the force is transmitted, but we also have a very short lever, because instead of the force being transmitted through the metatarsal heads, the force is transmitted through the navicular, which is the first structure in the foot that contacts the floor. So this greatly reduces the mechanical efficiency of soleus. So planovalgus foot shortens the lever arm of the soleus and also weakens the push-off power. Out-toeing gait is another common finding in children with diplegia, bilateral CP, and this is commonly due to external tibial torsion. So we saw that levers are, we saw levers in the sagittal plane, but levers also exist in the coronal plane. So if you have an external rotation of the foot, there is a shortening of the perpendicular distance between the point of action of the muscle and the where the force actually acts, which is at the metatarsal heads. So external tibial torsion and planovalgus foot shorten the lever arm of soleus, and that causes problems with good efficiency of gait. The other issue that we frequently face in CP is not just muscle shortening, but excessively long agonis, principally the quadriceps. So here the muscle becomes very short and the tendon becomes very long. This causes patella alta and a very long patellar tendon. The patellar tendon is in contact with the patellofemoral joint, and this reduces the efficiency of the quadriceps. So even at maximal shortening, the quadriceps is unable to generate adequate knee extension force, and this causes a knee extension lag when you examine the child in the supine position, and when you make the child upright, that causes excessive knee flexion in stance. So to summarize, the causes of crouch gait are flexible lever, shortened lever, and a malrotated lever. This is because of planovalgus and external rotation of the tibia. And in addition to that, we have a weak soleus, some of which may be iatrogenic in nature. We also have this positional lever arm dysfunction, the ground reaction force going posterior to the knee instead of anterior to the knee. And that again causes impairment of efficiency of the anti-gravity muscles. And as we saw, we have short hamstrings and iliopsoas causing hip and knee flexion contractures. And lastly, we have an excessively long and weak quadriceps. So it is not just one reason that causes crouch gait, it is many reasons put together. Symptoms of crouch gait starts, the family will come to you complaining of progressive loss of independence, typically over the previous 1 or 2 years. Many of them have knee pain. This is because of either quadriceps fatigue or an actual stress fracture of the patella. Many of these children come to us when they have already stopped walking. They have completely decompensated. They can no longer fight the forces of gravity, and they have stopped walking by the time they come. And typically, children with crouch gait present to us in the adolescent years. As part of the assessment, it's in addition to all the usual orthopedic history, it's important to take a detailed birth and developmental history. You need to confirm that it is cerebral palsy and it's not something else. So we would like to see a history about premature birth, low birth weight, history of NICU stay, etc., which points more towards a diagnosis of cerebral palsy. We want to ask them about what splints they are using, whether they're having regular physiotherapy, whether any previous treatment has been done, especially any previous calf lengthening surgery, which is a important etiological factor in the development of crouch gait. We also want to know whether they are dependent on any assistive devices, such as crutches, or whether they are in a wheelchair. So physical exam, the first thing we want to do is to look at their gait pattern, and you want to talk about the hip, the knee, and the ankle in the stance and the swing phases. So it's important to describe what is the gait pattern. And all of the eponymous tests, the Thomas test, popliteal angle, the Silverskiol test, the Phelps test, and Duncan-Ely test, I'm sure most postgraduates are aware of these terms. All of these tests basically test biarticular muscle length. So the psoas, the hamstring, the gastrocnemius, the gracilis, and the rectus femoris are all two joint muscles. And cerebral palsy is one condition that affects biarticular muscles more than uniarticular muscles. So in the iliopsoas, the psoas is affected and not the iliacus. In the gastrosoleus, The gastroc is affected, but not the soleus, etc., etc. So all of these tests, we will look at some videos that demonstrate these tests. And we also want to look at bony torsion. Many children with CP have excessive femoral anteversion and external tibial torsion. So this is a video showing the popliteal angle. So child is in the supine position. We take the hip to 90 degrees, and then we are extending the knee maximally. And the angle that the leg makes to the vertical is the popliteal angle. And then we are flexing the opposite leg and then checking the popliteal angle again. And then this is called the functional popliteal angle, where we are flexing the hip to 35 degrees and then checking, because the flexing the hip to 90 degrees is not a physiological position of the hip. During normal gait, the hip flexes only to 35 degrees. It doesn't flex to 90 degrees. So it's important to check whether the knee can be fully extended at 35 degrees of hip flexion. So this is a simple animation of a popliteal angle. So this is the way in which we normally check. We flex the hip to 90 and then extend the knee. But children with CP have anterior pelvic tilt, and because the hamstrings are attached to the ischium, that basically pulls the hamstrings down, and that because of the anterior pelvic tilt, the popliteal angle is falsely increased. So to correct for this, just like a Thomas test, we flex the opposite hip, and then we dial back the pelvis and then check for the true popliteal angle. So this is called the hamstring shift test, unilateral and bilateral popliteal angle. If there is a big difference in the popliteal angle between unilateral and bilateral, you know that the hamstrings themselves are not short, but it is because of the anterior pelvic tilt. And you have to be careful in doing a hamstring release in these children. This is the Duncan-Ely test, which checks for the rectus femoris. It's done in the prone position. And then we are flexing the knee and then looking for whether the pelvis is rising, which would indicate a short rectus. The femoral anteversion is checked with the gauge test. Again, in the prone position, you check hip internal rotation, and then we check for external rotation. And children with excessive femoral anteversion will have greater amount of internal compared to external rotation. And then place your hand on the greater trochanter and check when the greater trochanter becomes maximally prominent, and the angle that the leg makes to the vertical is the angle of femoral anteversion. Thigh foot angle, which checks for tibial torsion, is again performed in the prone position. And then you put a goniometer, one parallel to the axis of the foot and the other parallel to the axis of the thigh. And that gives you a thigh foot angle. And 10 to 20 degrees of external thigh foot angle is within normal limits. So during physical examination, we also check for presence of hip and knee flexion contractures. We check the strength of all major muscle groups. We check for spasticity, and we can use the Ashworth scale or the Tardio scale to check the severity of the spasticity, look for patella alta and knee extensor lag. And we also check for point tenderness at the distal pole of the patella or in the tibial tubercle, which might tell you about a stress fracture. Imaging studies, we have to perform an AP pelvis radiograph in all children with CP. And the GMFCS level 3s and 4s, where we have crouch gait, up to 50% of them can have hip displacement. Standing AP and lateral radiographs of the feet are important. And we also do a lateral radiograph of both knees in 30 degrees of flexion or in the maximum possible knee extension to look for patella alta. So this is a 9-year-old boy, GMFCS level 4 CP, who came to me with knee pain. And when we performed a hip X-ray, we found that he had actually left hip subluxation. So in all children who come to you with crouch gait, you should always check to make sure that they don't have a hidden hip displacement, which is quite common in cerebral palsy. So this is a typical lateral X-ray of a knee in a child who came to us with crouch gait, 13 years old, GMFCS level 3. You can see that they have a 60-degree knee flexion contracture. That's the Blumensaat's line, and the lower pole of the patella should normally be at the Blumensaat's line. Here you can see that there is significant patella alta, and there is also a stress fracture at the lower pole of the patella. So these are all common radiographic findings that you see in crouch gait. In addition to imaging, we also do in walking children, we do 3D gait analysis. This is our 3D gait lab in Bangalore, where we have infrared cameras, we have video cameras, we have a force plate, and then we have a powerful computer that generates musculoskeletal models for us, such as this. And using this, we are able to estimate things like muscle lengths. We are able to do very detailed kinetics and kinematic studies that helps us to make a scientific and rational treatment plan rather than just doing hamstring releases in all children with crouch gait. So moving on to treatment, the three factors that determine how we treat crouch gait is age, GMFCS level, and the severity of the deformity. Crouch gait does happen even in younger children. In younger children between the ages of 6 and 8 years, we typically do non-operative management, splints, in which ground reaction AFO is the most appropriate splint for a child with crouch gait. If there is spasticity, excessive spasticity in the hamstrings, we use botulinum toxin injection and stretching cast. But it's important to remember that it is advisable not to operate in children who are younger than 8 years of age. Typically, we wait for gait to mature. That happens around the age of 8 years, and then we think about surgical intervention. Between the ages of 8 and 13 years, here the children are in moderate crouch gait, where they have a knee flexion of more than 30 degrees in the stance phase of gait, but they have not yet developed a knee flexion contracture. Many of them have lever arm dysfunction, as we have discussed. And in these children, we do gait improvement surgery, which is a single stage procedure that corrects the hamstring contracture if it is present, plus we address all the lever arm dysfunction. So we do judicious muscle lengthening surgery. Over lengthening of the hamstring causes anterior pelvic tilt. It causes recavatum gait, hyperlumbar lordosis, and also low back pain. And these are all detrimental to the walking of the child in the long term. And rather than doing a complete ZUD lengthening of the tendon, these days we tend to transfer semitendinosus to the distal femur, and this preserves the hip extensor function of the hamstring and mitigates against the effects of anterior pelvic tilt and lumbar hyperlordosis. So we have to do careful myofascial recession of the medial hamstrings only, and we never release the biceps in walking children. So this is an example of a child who had iatrogenic recavatum, and this is because of an overdose of hamstring lengthening. So this child was walking in mild crouch gait prior to surgery, but after over lengthening of the hamstring, you can see that the gait has significantly deteriorated. So it's very important for us to do very judicious muscle lengthenings rather than excessive muscle lengthening. In adolescence, we get severe or neglected crouch. This is where children have an established knee flexion contracture associated with lever arm dysfunction. And in these children, the aim of surgery is to preserve walking ability if they are still walking, or if they have stopped walking recently, we restore their walking ability to whatever extent possible. And many of these children have severe knee pain, and surgical correction also relieves them of knee pain. And crouch correction surgery typically involves performing a distal femoral extension osteotomy along with patellar tendon advancement, either through the soft tissue or through bony advancement of the tibial tubercle. And in addition, we correct the planovalgus foot deformity and the external tibial torsion. So this is the child, X-ray of the child who presented to us with severe crouch gait with a knee flexion contracture. We remove a trapezoidal wedge of bone that is anteriorly based, and then we close the gap, and then the patella is pulled down in order to retension the extensor mechanism. And this is the post-op where we have fixed it with a locking plate for stable fixation. And you can see that the patella is moved almost down to the joint line in order to retension the extensor mechanism. And this is the typical sort of crouch correction surgery that we do. Just to give you a clinical example, this is a 12-year-old boy who came to us with moderate crouch gait. You can see that his patella alta is not too significant, but he is walking in about 60 degrees of knee flexion. He did not have any foot deformity. And this is 2 years after distal femoral extension osteotomy. You can see that he is walking much better. He is achieving knee extension and stance. But thankfully, because we have been careful about not over lengthening the hamstring, you can see that he is not in significantly increased anterior pelvic tilt. So this is a Crouch story. It's a 12-year-old boy who initially presented to me. This is in 2013. You can see that he is in crouch. He underwent a left hamstring lengthening, right femoral extension osteotomy, and we also corrected his lever arm dysfunction. This is 2 years later. You can see that he is walking much better, but he has got some external rotation of the tibia. So subsequently, we did bilateral tibial derotational osteotomy, and this is him at 19 years of age. He's attending college. He can walk 1 kilometer. He's complaining of a little bit of right knee pain, but it's actually his straighter knee. His slightly bent knee is actually quite asymptomatic, and he has managed to keep up his function throughout adolescence. So just to summarize, crouch is a serious gait disturbance in CP. It should always be treated actively. Various etiologies, as I've outlined, have to be identified and they have to be managed simultaneously. It's important to avoid iatrogenic crouch gait, which is because of over lengthening of the Achilles tendon. And treatment is based on the age, GMFCS level, and severity of the problem.
Thank you, Dr. Jain. That was really wonderful. Really wonderful. I so many things I might have learned, meaning that I thought I have read about it, but still it was very, very informative. And to the students, I think you have to probably listen to this again and again for everything. I'm not even talking from the exam point of view, in also in the pay of management of these children. Dr. Lalit, please. Lalit? Lalit, are you there? Okay. Dr. Ray?
Yes, I've come back. Yes, I've come back.
Yeah.
My internet connection is really unstable, so sorry about that. So Jayant really did a very, very exhaustive job, and I think there's really nothing much to add from my side.
I don't think any of us can add anything more to what he said. It has been exemplary, and he had covered it. And one thing I think we should mention was the excellent slides. That was really very, to be very frank, that was easier to understand by the line diagrams than even
animations.
Yes, that was really.
The animations really help.
Really. Dr. Ray?
I have nothing to say, sir. I have learned many things. He has covered everything. Only one thing I want to know that is there any age group of this surgical treatment of such patients?
So we have
patients are coming from this younger age at what up to the what age and at what age you should.
So as a very approximate guideline, we have 3 groups: children who are less than 8 years, children between the ages of 8 and 13, and children who are older than 13. In children aged less than 8 years, we avoid surgery at all costs. So we use non-surgical measures, we use physiotherapy, Botox, stretching casts, and splints. And we try and push them to beyond 8 years because we want to allow the gait to mature, and we also want to allow the spasticity to go down. Because in children younger than 8 years, spasticity predominates. Many of them don't have contractures, but by 8 years of age, naturally the spasticity has gone down. So whatever remains at 8 years is more likely to be due to contracture rather than spasticity, because we don't want to do orthopedic surgery for spasticity, because that causes over lengthening. That is the main reason for over lengthening, is the muscle is actually spastic. It is not short. So we release it and we lengthen it. And by 8 years of age, when the spasticity naturally goes, the muscle becomes weak and too long. So that is one of the main reasons why surgeons have indirectly contributed to crouch gait. But that was because of our lack of understanding, maybe 20, 30 years ago. But now we understand not to do surgery at a younger age, wait until they are 8. Between 8 and 13 years, typically we are able to manage with soft tissue surgery. But even when we do hamstring lengthening, these days we are doing only medial hamstring lengthening. We are not touching the biceps, so that at least there is some contact between the knee and the pelvis. Because not only is the hamstring a knee flexor, it is also a augmenting knee hip extensor. And that hip extensor function of the hamstring is very important. If we lengthen all the hamstring, loss of...
I can't take the call. I can't take the call. I can't take the call because I'm in a webinar. Amma, I'll call Amma. Aravind, sorry.
So the other reason, so that's why we do medial hamstring lengthening. And these days, there is a trend towards doing... I wanted to show you the house. I'll show it tomorrow.
Sure.
I know. So these days we are doing conservative hamstring lengthenings in the 8 to 13 year age group. And in children over the age of 30, typically it will involve bony surgery in the form of a distal femoral extensor osteotomy. So those are the three main age groups that we consider with regard to crouch gait.
Then I have a small doubt. What about this Botox? I mean, it doesn't completely destroy, so does it recover later?
There is new data now which says that repeated Botox injections is not a good idea because it causes some permanent loss of muscle fibers. So we say maybe 1 or 2 Botox injections that are timed when the spasticity is maximal. So between the ages of 4 and 6 years, when spasticity is really significant and it is interfering with the gait, it's interfering with the therapy, it is interfering with the ability of the child to use splints. So at that time, we give Botox, which just buys us about 9 to 12 months of time. So by then, the child has also progressed a little further in terms of their overall motor development. So in my practice, it is a get out of jail card. So if I have a 5-year-old child who is starting to develop a contracture, I can't operate on them at 5 years of age. So I do Botox, stretching cast, and splints with physiotherapy and push them as possible before considering any surgical intervention. But it's important not to do repeated Botox injections because repeated Botox also is harmful to the muscle.
Thank you. Thank you. Doctor, if I think we are, is it 8 o'clock now, Dr. Lalit? Dr. Lalit? I think it's not there. Okay, I think we will, Ray, anything more, Dr. Ray?
No, sir. Okay. Everything.
So I think at the end it was a very, very, I actually have a lot of more questions, but with the students, I don't want to ask them because that shouldn't confuse them. I will go to the next talk, Dr. Rujita. And by the time Dr. Rujita shares the screen to the students, I think this is the most common among all pediatric orthopedic problems. And you all sometimes think as an easy case, but end up doing badly sometimes. So I'm sure this talk by Rujita is something going to be very, very important for you. Over to Rujita.
Well, thank you very much, sir. And thank you everyone for this really good initiative of continuing PG teaching. So like Professor Rajgopalan said, yes, you will never be forgiven for not knowing everything about a few conditions, CTEV, Cubitus Virus, and small lumps and bumps which you would get as short cases. Remember that these are scoring, and what the examiner expects is a very, very quick evaluation and a chance that you would lead him on to all the things that you know in theory about CTEV. So without much ado, let's begin. I will try to show you only what I would expect as an examiner from a postgraduate. So basically, when we talk of neglected CTEV, it's basically a misnomer, and it's considered impolite nowadays to use the word neglected CTEV. It is best to relate it as an untreated or a walking age clubfoot. What is it? It is a clubfoot that has never been corrected before the child has started walking. And now that he has started walking, the deformity itself has changed over a period of time. And hence it may require more severe measures because the bony contractures and the soft tissue deformity may have varying degrees of suppleness or rigidness. So one method or one-stop shop may or may not work with these kind of children. It is not the same as a recurrent or a relapse CTEV, which is in essence something which has been treated before, but a specific component or 2-3 components of a deformity have recurred. And in essence, it is the whole foot, which was previously could have been treated with a simple method, has now become untreatable or difficult to treat. And what are the reasons? Either there are social reasons or some compulsions that some of the children do not come soon after birth for treatment. Maybe they are from far off villages, and hence those factors have to be kept in mind when you plan your treatment. Or maybe if it's a syndromic child, they have some other visceral problems which have been on priority, and hence it may pose an issue to fitness. Hence you need to know the reason also why the delay or the neglect, so-called, which is the term to be given up now, or why did the child remain untreated. It comes in many varieties. For example, this may be this was an MMC child. So even if this looks like an untreated CTV, it is essentially flail in the peroneal component. So the etiology is also important. Or a 3-year-old simple supple clubfoot, where the child is walking on the lateral border, but essentially it is pretty much correctable. So will be amenable to much more simpler plaster casting and treatment. Or something very complex like this, a spondylocostal dysplasia with an Escobar syndrome, where there are multiple problems in the body, and hence the CTV got a little less in the priority. And now that the child is walking, but he is walking improperly, the parents have come to you for treatment. So you need to examine the child as a whole. You need to quickly tell the examiner that this is an untreated CTV of what etiology and what functional disability. When looking into the causes, of course, do not forget to turn the child and look for a spina bifida or a neuropathic causes. And if you're dealing with syndromic children, the commonest ones are arthrogryposis on amniotic band syndrome, which is in essence makes this child or this clubfoot a little difficult to treat by simple conservative methods, but it is still can be done with Ponseti with a few caveats. You just have to know how and when. Or it may be an idiopathic clubfoot, which did not get treated because the child was staying somewhere far off. And it was essentially then a clubfoot which was difficult to completely correct with Ponseti. It may have hindfoot or midfoot contractures which are tight. And you may be actually looking at the tip of an iceberg. Sometimes these are very subtle syndromes and therefore mistaken as a idiopathic CTV. Or you may be dealing with an atypical clubfoot, which is a result of an iatrogenic manifestation of Ponseti treatment. So in 10 minutes, what you need to tell the examiner is speak the relevant points, bring out the positive findings, which are most important because they are going to decide your management. You must give a salient negative history to show the examiner that you have been through each and every aspect of etiology. And you must demonstrate a logical approach to decision making. So in which there are a few factors which will make a lot of difference. So you need to tell the age of the child, the laterality. If it's a unilateral clubfoot, it's going to be surely smaller and maybe easy to treat. For example, if you elect in an older child, if you decide to do Ponseti, it may still be easy to keep this child mobile by giving him below knee plasters and crutches to walk on. But if it's a bilateral clubfoot, you may not be able to offer the same. You also definitely need to tell them about associated features if there are hip, knee, and spine contractures, for example, in AMC, which will make your plastering treatment that much more difficult and may point more towards in the direction of surgery. Previous treatment, if any, will not apply in this case because we're talking about untreated CTV and the overall prognosis. So all these points must come out in one line in your diagnosis quickly so that the examiner can then ask you as to what you saw. And you must remember the 4 basic tenets of orthopedic examination, that is look, feel, move, and measure. And look, feel, move, and measure, look at the midfoot, the hindfoot, and the forefoot. In the midfoot, do not forget to look at the medial midfoot piece. Note that the navicular bone is usually fixed to the medial malleolus because the child has already started walking on it. The cuboid is medially displaced. There is a very vivid curved lateral border of the foot, which may be difficult to correct. And there is no mid-tarsal mobility if the child is persistently weight bearing on the dorsum of the foot, unlike the child that I showed you previously who was walking on the lateral border. There are 2 types. Either they walk totally on the dorsum of the foot, right, that is right on the apex of the deformity, or they walk on the lateral border. And that would tell you that this is much more severe and will probably need surgery. Look at the hind foot, because the heel then is in significant varus because the talus is totally displaced and it's an equinus. And there is also medial rotation of the tibia since the child has assumed the erect posture. The calcaneum also is an equinus, varus, and internal rotation. So the entire hind foot complex has become fixed, rigid, and displaced. And then look at the forefoot, which may still be a little correctable, but the pronation of the forefoot will be very apparent, and especially the depressed first metatarsal, which will result in a deep cavus. So you need to remember that the tripod will not be balanced unless you treat all three at one go. So look from the horizontal plane or from above to look at the top medial rotation of the talus, as you see here. Look from in the sagittal plane from the medial side where you see the equinus deformity, the medial crease, and how deep it is. And look from behind or the foot end of the child where you will see adduction deformity as well as the varus. And look, feel, move, measure everything and score simultaneously. You may ask me, how will I score a child who is already so advanced in age? So, well, classically, the Pirani score was developed in neonates, but as a largely followed practice, most of us still rely on the Pirani score. We will not go into detail because I think previously in one of the lectures, Dr. Anil Mehtani has already covered this. But this is for a quick recap. You need to know the hind foot score and the midfoot score, and you need to give a total score. So you must quickly evaluate that. To pictographically show you this, it goes from varying grades of 0 to 1 in terms of severity at all three parameters. Again, same way, varying grades of 0 to 1 in all three parameters. After that, you will look at the contractures of the hip, knee, and spine. Why? Is because you need to prioritize correctly. For example, if a child is arthrogrypotic and has come late for treatment, but the knee is also dislocated, in terms of priority, if you're planning to start serial casting, then if the knee is dislocated, you may not be able to give a good above knee plaster. And therefore, you may need to prioritize the knee over the foot or need to do them simultaneously or do some sort of operative intervention at the knee first and then go ahead with the foot. And why? Of course, because you need to establish the correct etiology in order to prognosticate. And the other reason, the third why, is that it tells me what to expect and tells the parents also what to expect in terms of duration of the casting or the treatment. Can you combine two surgeries if there are two maladies present? And how many interventions am I looking at if I'm talking of surgical interventions? Radiographic evaluation is by and large given up in the neonate, but when you're talking of a walking age child, it is rather important, especially if the child has come to you towards adulthood, which we still do see in our country when they come from far off ages. And therefore, remember these two things that I'll point out to in the AP, the talocalcaneal angle and the talar first metatarsal angle. And in the lateral view, the tibiocalcaneal angle and the talocalcaneal index. So these two things, if you are really scoring well, the examiner will ask you. But by and large, they will be looking at how you've done your clinical examination and what is going to be your approach to this particular child. So once this has been achieved, do not waste time on giving them a feeding or nutritional history and immunization history. Do tell them if whether siblings are affected or whether a father, mother was similarly affected, because that tells you about the severity of the CTV. And tell about the milestones, particularly if you're looking at a syndromic child and if it has been late. Even if it's an older child, if he has not achieved the milestone of standing, that will immediately change your management to doing things like conservative management. And do tell the examiner the details of the reason for bringing the child late, from the anesthesia purpose and decision-making purpose to choose the modality of treatment, and also tell them about the socioeconomic status. If you're so far doing so well, and if you at least done your Pirani scoring well, then the examiners may ask you about if do you know any other scores. In that, the most important ones now will be Demeglio, because this can still be used for a lot of clinical evaluation as well as outcome evaluation. Catral and IFSC are things, if you are really doing well, you may really score well. But by and large, it's most important. IFSC is not really followed now worldwide, and Catral is pretty old. So Pirani and Demeglio have really stood the test of time. These two scores you should know. You should know the difference in each score and what type is each score. So quickly, if I take you through the Demeglio classification, what they've done is looked at each major component, that is equinus, the hind foot varus, the mid-foot rotation, and the forefoot adduction. Basically, the degrees of correctability and the components that need to be correct in the clubfoot, and they're graded from 4 to 1. 4 being most severe and 1 being mild. And then there are additional points for what is some of the features of the Pirani score, like the posterior crease, medial crease, cavus, and poor musculature. Cavus is a very important component of the older or the untreated clubfoot, and hence this has been built in. And therefore, to my mind, DiMeglio is a much better evaluation score for an untreated or a neglected clubfoot. And then there are these details. This can be read up in the books, so we will not waste too much time on it because we want to quickly take the examiner to what will you do. So look at that, equinus going from degree of correction to a good dorsiflexion, bringing it down to 0. Hind foot varus again going from a very severe hind foot varus to actually achieving overcorrection, which brings it down to 0. Mid-foot rotation from a supinated foot to a pronated foot, which is able to achieve to 20 degrees, that is called 0. And then the forefoot adduction. So basic 4 components again in the same way. From an adductus, if you can achieve an abductus of 20 degrees, so degree of correctability, bringing it down from 4 to 0. And then the extra points. And for each point, if it's absent, mark a 0. But if it's present, any of the extra points, then put a 1. And then you go for a total score. And then it fits into one of these categories. So IFSC classification, just for completion here, we are mentioning it that it looks at the rate of the deformity, the passive motion, creases, and the muscle function. There is a chart available if you go onto the website, but we will not look too much into detail here because I think most examiners now have moved away from this. So just as Ponseti can be applied to a neonate or children below 1 year of age, can it be applied to the walking child? We recently wrote this up and it's got published. The details are there for you to see. What is the upper age limit and how long can we try Ponseti? And if so, what are the caveats along with this, or what are the modifications that you need to do the Ponseti technique if you do apply the Ponseti technique to a neglected or the better word for it, a untreated clubfoot, or the way we prefer to say walking age clubfoot. Those are some of our results. That's an 11-year-old child who came with a unilateral neglected CTV, completely corrected with Ponseti and a mild posterior release. And again, another 13-year-old boy, completely corrected, very well plantigrade. So it is possible, but what happens is the problems of Ponseti in an older child is that an above knee cast is extremely difficult to manage, much more so in the bilateral cases, and carrying the child or ambulating this kind of a person, especially if he's 12, 13, is a big problem, and they go on to a wheelchair, which a lot of people don't accept. Hence, the following modifications have to be made, that a 90 degrees flexion cast is given at the knee rather than a hyperflexion at the knee. You can reduce it to 70 degrees so that they can keep the knee slightly extended and sit in a wheelchair. And you have to counsel the parents that initially the walking may not be possible and there'll be a little problem. These children are stiff, they sometimes get pain, and they may need some sort of orthotic support or a lot of long rehab before they can go on to walking well, but it saves the morbidity of surgery. Again, there is, when you give them splints, you cannot be at full 70 degrees in abduction, and hence adherence to the braceware is a problem. So give it only at night, and sometimes in some cases you have to compromise with an AFO. If you're giving a Steenbeek for the night time, then you have to accept only about 40 to 50 degrees of abduction and not a classical foot abduction brace as described in Ponseti. What is the safe age for a tenotomy, and when should we do an open lengthening in these children? After 10 to 14 casts, which is what they usually require. So this is another important thing that you have to counsel, and you have to be able to convince the examiner. We will do a limited open lengthening provided the lateral border of the foot has become straight. And you do not do any percutaneous posterior capsulotomies or TA tenotomies here. In fact, you open it out and do a limited posterior release as was classically described long back by Attenborough. And those are the kind of results that you can get even in a 36-year-old mother of a CTV child who successfully, once we had treated her child, she then lifted up a sari and told us, can you do the same Ponseti technique on me? And we had to use a very small osteotomy at the apex of the deformity here. We had to begin with a plantar fascia release here, that is relieve the cavus. About 17 casts were applied, and then a small osteotomy was done and a limited posterior release, and that's the kind of result she had. but it requires a lot of patience, it requires a lot of training, and may not be possible for everybody. So if you've been trained at a center where this is possible, then go ahead and they say this. Otherwise, stick to what you would say standardly, that there are cases where, especially if the child has come from a far off place, that you would do a PMR. PMR is not totally defunct. You can use it for a late presenting supple foot, which has been neglected so far. Or you can use it in cases where there are multiple congenital anomalies or with syndromic association, or if there is a socioeconomic problem for which the child cannot really afford to stay till all your plasters are finished. To quickly show you some surgical steps, because PGs, I think these days don't really get to see too much of a PMR. That is the position that we use on table, a complete lateral, so that all the structures, the entire deformity is there in front of you, and you can easily access posterior, medial, as well as anterior, and on the plantar surface. Those are the structures. If I may orient you, we are going to go from posterior to medial there. So that's the tibialis posterior. That's the tendo-Achilles. That's the FHL, which is close to the tendo-Achilles, right near the ankle joint. That's your tendo-Achilles lengthened and Z divided, if you can see clearly over here. And that's the arrow over here shows you the ankle and the subtalar joints. And that's your talonavicular joint there. And after the master knot of Henry has been released. So it's important to know what structures to release, and you can get a really full, complete correction. And never forget to do your plantar fasciotomy and also the abductor hallucis release, because these are the commonest residual deformities which are left behind. And you can get beautiful results as good as this one. If the skin and soft tissue creates a problem, we've described a rotation fasciocutaneous flap in Vadia, where you bring glabrous skin down to the medial portion, which often necroses, and then this closes by primary intention. You could also use the Cincinnati approach. Of course, it gives you a very overall rounded exposure, even as far as the lateral side, if you're doing a complete subtalar release. But the TA or the TA lengthening has to be done in a very guarded fashion, and sometimes it's difficult. In experienced hands, it works extremely well. When you're talking of an untreated or a neglected CTV, I think two things really stand out, and which is the use of fixators. So if you're looking at just distraction, then that is one of the most significant contributions made in the Indian scenario. I personally prefer it, and it is ideally suited to this deformity because it is a controlled differential distraction, which means you can increase the rate of distraction on one side and decrease the rate of distraction on the other. And it differs from classical Elixir technique, which people like Dr. Dhawan and all are used to, is in terms that it does not use actually tensioned wires, and the frame is unconstrained and therefore modular. And every few days you can actually redo it and take the child under anesthesia and correct the deformity faster. So what are the components of it? There are three assemblies: the forefoot assembly, the hindfoot assembly, and the leg assembly. The fixator wires take hold into the forefoot, the hindfoot, and the tibial assembly as described over here. And the fixator actually then performs all the stages of the Ponseti, if you really look at it that way, by eliminating the cavus and then gradually abduction and unlocking the talus in the subtalar joint. So to show you another view of the forefoot and hindfoot assemblies, and then the paired distractors as have been shown over here, that's the foot distractors, and this is the equinus distractor, and this is just a straight connecting rod just to stabilize the frame. So what is the distraction protocol? The examiner will ask you. This is what you have to say, that on the medial side you distract more, that is 1/4 turn 4 times a day, which means a full turn of 1 millimeter every single day. And the lateral distractors you will distract less, that is half a turn just 2 times a day. So what happens with this is there's a linear distraction of the soft tissue. You can do a weekly readjustment of the frame in under pedicloral in the ward itself if the child is cooperative. For very tough situations, you could take it under anesthesia after 15 days. Where the distractors simply are detached, the frame is re-rotated or the foot is re-rotated, deformity is corrected or abducted, and then the distractors are reapplied and distraction is done for a few more days. how does it work? It works exactly like the Ponseti, where the collagen cross-links take 4 to 6 weeks to mature, and you gradually elongate the soft tissues and correct the deformity. And then what you must not forget is to mention to the examiner a holding mode after correction is achieved. And the frame retains the correction better than the cast. So then after that, with the suppleness, you can directly mobilize the child. So one quick example, this child with the Escobar syndrome, that is his foot, in a very, very severe, nearly the plane of the foot and the plane of the tibia were almost collinear. There we applied a Jess distractor, and this is the kind of beautiful correction that we got. Yet another 14-year-old child where we applied the foot frame, and that's the kind of result that we got. Of course, this was then followed up with a soft tissue release. So you must remember to mention to the examiner about the elastic recoil of the soft tissues in particularly in an older age group. And therefore, after removal of the frame or with the frame on, complete your soft tissue release and then go on for retention for some time. And that's his result with a hybrid method combining both the fixator and soft tissue release. In some cases, if you're not used to fixators, you may have to combine the soft tissue release with bony surgeries. And these are still pretty much done. Some of them correct just the shortening of the lateral column, which gives you a very good lever and achieves the good abduction correction there, or a decancellation of the cuboid, which is the commonest surgery that we perform in conjunction with soft tissue releases. The Lichblau and calcaneocuboid osteotomies are shown here, where you just excise a significant wedge and correct the heel varus. But the rest of the forefoot and the midfoot component should have been corrected for that. Lichblau is something which usually one does not do anymore. So just remember to tell in the examiner the decancellation of the cuboid or a calcaneocuboid wedge excision. Those are some of the results where we did a hind foot isolated correction and then fixed it with a K-wire, and that's the kind of result that you can get. And this was another child where we did a decancellation of the cuboid along with the calcaneal osteotomy. In very select cases like this 23-year-old child, they may ask you, what about triple arthrodesis, where it may be so painful and the patient desires a one-stage correction. There you may resort to doing all three joints, big wedges have to be removed, but you also have to caution them that this is an acute correction, and hence the foot size may change and the foot may really look pretty much short after the triple arthrodesis is done. Of course, in bilateral cases, that is, it's easy. In unilateral cases, it stands out where the foot size changes a bit. And some other examples again, where Elizaro has been used. This is something which I have no personal experience with, but again, the principles are the same. They have a tibial assembly and the foot frame, and again, same gradual correction is used. And those are the kind of corrections that we can get. So to summarize, I will say that, Dr. Ponseti said it's our job to straighten his little feet. And whichever method works best in your hand, that you must remember. So when you're talking in an exam, try to lead the examiner on more and more onto the treatments that you know. So assess objectively, manipulate and do serial plastering. It is pretty much accepted now, but do mention about the close follow-up. Select the method as per your expertise. You must know to talk about fixators and a little bit about the osteotomies. If you are asked about soft tissue releases, do say that yes, it is okay to do it when indicated, and release radically so that deformity is corrected at one go. Which three joints are most important in the release? The ankle, the talonavicular, and the subtalar. And the three ligaments that you must release if you are doing a PMR, that is spring ligament, calcaneofibular, and the talonavicular. And the three tendons that you must release are the tendoachilles, the tibialis posterior, and the FDL. So with knowing this much, I think I'll stop share here and I'll invite any questions.
Thank you, Dr. Rajita. It was really excellent, and you have covered everything, and all the points with the postgraduates can get trapped. You have emphasized that. That was the most important thing. At the same time, you gave us overall knowledge for them, and it was very good. Dr. James, anything more you would like to add about it, or anything more that the students should know?
I think that last slide was excellent.
I think the most important thing is to know what works in your hands, and whatever method you choose, you have to be able to justify it with all the points well covered.
Yeah.
Because clubfoot in itself is very exhaustive, and I think no single lecture can really do justice to it. But yeah, in exams, you have to know a little bit about all the methods. That's very important.
Very true. Because he doesn't know who the examiner is sometimes, what he
Whether
wants.
it's an old timer or a new pediatric orthopedic surgeon. So right from plasters to the end of the spectrum, you have to be able to tell.
Actually speaking, he might be prepared for a pediatric orthopedic surgeon, and people old like me come and ask some old procedure, then also they get trapped. That is another problem.
Yes, that's why it is. And sir, I would not say really it's old or anything. I think we forget that in India, we see all this spectrum and we should know how to. I think a good surgeon should have everything in his armamentarium and know what to use when. It's only in the West that they get babies referred really early and they don't see some of, tribal area patients and things that we still see in the rural, urban camp scenarios in, district hospitals. So I think it's good that Indian students are exposed to everything.
Very true. Jen? Something you were telling, Jen?
All treatments can be employed judiciously at any age. So I think it's better to say that many treatment methods are possible and just to give a short overview of all the treatment methods rather than to commit to say, I will do this or I will do that. Just say there are, depending on the particular age of the child, the severity of the deformity, it's possible to employ whichever treatment is suitable for that particular child. I think Rujita has really covered the entire gamut of treatments.
Very true, Jayant. What she did, is exactly what I want, because in the examination, we have a different type of people. Each person may ask for what else. So at least if he doesn't tell everything, at least the principles and names he tells, which is almost everything covered. Professor Ray? Ray, what do you like to?
I have nothing to say. Rujita has covered everything really, and all the practical things that usually asked to the postgraduate that she has also covered. One only practical thing, my own interest, that do you recommend any soft tissue stretching or period of conservative treatment before you recommend the surgery, and that conservative in the form of plaster? Does it help in surgery as your experience?
So yes, sir, if there are the parents are willing to wait for some time, then before embarking on the PMR, if it's a supple foot, it will really help if 2 or 3 plasters can be given. But if it's a rigid foot, then I will use the same Jess frame to achieve the stretching and then go on with my soft tissue release. Because the Jess also has a rebound effect which nobody really talks about. So if you just simply do a stretch and leave it, after some time it does tend to recoil. But if the children cannot wait, if they've come from a very far off area, then it is better, and it's a rigid foot, better to resort to bony osteotomies and shorten the column or shorten the excursion that the soft tissue has to be put through. And then you can continue with subsequent plaster changes. But if it's a supple foot, then I think my bias would be more towards doing plastering rather than a PMR, unless the patient cannot wait and has to just finish within 1.5 months everything and leave. Sometimes you do get patients from even places like Africa and where you have to quickly choose a surgical method. That time I would not go in for pre-op stretching. But for a child who can come, it's justified enough.
Yeah.
Dr. Lilith, are you there?
Yeah, I'm there. Excellent lecture, Rujita. You revised the whole thing. It was like a PG lecture for me. I don't do much of pediatrics. Could you please re-emphasize or re-clarify certain terminologies in which at times examiners entangle students, like neglected, relapsed, recurrent, resistant, syndromic, and partially treated CTV. So what are the accepted terminologies students should know?
Yes, so neglected is a word examiners still like to use, but in international nomenclature, it is given up. So it's better to say untreated or walking age. So we personally at Vadia, we prefer to use the term walking age so that you at least know what you're dealing with and you know that this can have a wide spectrum. And even if the examinee makes a little bit of a mistake, it's still all right if he uses that agent. Relapsed or a recurred CTV is clearly something which was treated and then some part of it came back. So either one component came back or several components came back. So then you look at what came back. For example, if just the equinus came back or if the forefoot adduction came back, then the treatment offered is again recasting and retenotomy. But if you say something is partially treated, then I think there's not much difference. Those are loose terms. The three standard terms are either treated, untreated, and relapsed CTV. Relapsed and recurrent are almost the same. There's no difference between the two.
Okay. And how much should a candidate know about the various types of braces and shoes and calipers, the historic ones and the current ones?
So calipers, I think they need not really worry too much about. There are two things they must know about. One is the foot abduction brace, which is the standard Ponseti one, how it is measured, how it is given, what is the rhythm that they follow. What is the exact, like I said, the 70 degrees angle and shoulder length. So those are, I mean, it's a lecture in itself about the foot abduction brace. And AFOs. AFOs are largely used where you have a syndromic child who's come late and who has a knee and a hip contracture as well, which has been treated, where you have to, no child beyond 2 or 3 years of age is really going to sit around with both the legs kept in wide abduction like that. So for those children, AFOs in the daytime are acceptable, or even sometimes even at night. There are some really cranky children who have severe compliance issues and just don't accept a foot abduction brace. Their AFOs mounted on a rod are also sometimes accepted.
So what has happened to the CTV shoe? What has happened to the CTV shoe?
No, it's no longer used.
So it's in the museum. So all the examiners on the panel should stop keeping it in the Viva?
No, I think it's a prize question, so it's fine to keep that. We used it. I mean, I think we are probably that dated now, Jay and I, as residents, we used to see it.
It's still there in the last edition of Stewart.
Yeah.
It's still there.
And PMR was one of our commonest surgeries before. Now it has got wiped out practically. Yeah. So there are these select indications which I thought it's important for them to know and see.
Thanks, Rajita.
Yeah. Sir, you need to unmute yourself. Rajgopalan, sir, you need to unmute.
I think one thing is what Dr. Rajita said, I think is very important. The scenario you see in India, particularly in the metro or urban area, you don't find so much of walking ages thing. But in I work in I can call a rural area or semi-rural area, but you still see people coming in like that. Even adults who come into the hospital as a bystander, totally neglected and totally untreated, and they still continue on that. So different scenario. I once had a second year students, MBBS, who did first year in some other college and got transferred. She had a CTV at the second year of MBBS. It was 45 years back. She got a triple arthrodesis done by my chief that time. The spectrum is different in our totally this thing. And CTV issues, something we still keep in the exam. I have to accept that. I can't say no. Thank you, Rajita. It was very, very useful definitely for me, and I'm sure for all our students. Any other? I think thanks everybody, and thanks Jayant. You have spent the whole day with us and evening with us, and I delayed your talk too. And thank you so much. And if there's anything else before we close, Dr. Ravi, anything else? So I thank all of you.
had something to say.
I just had a quick announcement to make. Tomorrow morning from 9 to 1, we have a Bombay Orthopaedic Society Master Series on angular deformities around the knee. So those PGs who are interested, just go on to the BOS website and log in. And again, it will be one more round of pediatric ortho exam cases for you all to see.
Oh, very nice. That will be very nice. I will inform with the groups I have. That will be very, very nice. And we have finished one of the earliest. I mean, Ravi, we are almost earliest so far.
Almost done, sir.
So otherwise, it sometimes goes later. Thank you all. Thank you, Jayan. Thank you, Dr. Gita, Hitesh, and Dr. Mauli. I will inform later. Thank you, Dr. Ray. And Lalit, I will not say thanks to you as usual. Lalit is a team. Okay, thank you, Ravi, and thank you all. And lastly, Ravi, any questions have come in so far?
Not yet, sir. Not yet.
We won't know. Some of them might have gone in the thing. If the questions are there, usually they come only for the next session. We'll let you know. And we'll have next Saturday with today one faculty left out. I don't know whether we'll be able to include because already it is going beyond this time. We'll see about it. Thank you all.